Uh, Hi. So a couple of you were with me for the last class, and I think Leah is new. So to the ones who are here for the last class, did you guys get time to review the previous material?
Very little.
Any doubts? Anything that you want to clarify?
Just
Sahil?
2 minutes. I had some doubt.
Yeah, sure.
2 minutes.
Sorry, I didn't find the time to review that. In future I'll review them and I'll ask question if I have any doubts.
Yeah, sure. No issues. Try to keep up with us so that by the end of 6 months you're ready with everything, right? So try to keep up with us.
Yeah, that's I know because in our university we had midterms and finals together in these
Yeah,
months. So sorry for that.
cool. Yeah, totally
I
understand.
had a doubt in vitamin A deficiency resulting in metaplasia.
Cool. Something specific about it or just a phenomenon?
Just like I not understand the phenomenon of how like vitamin A deficiency is causing this metaplasia.
So, vitamin A is usually so it's a micronutrient, right? It's part of a lot of reactions, and some of the reactions that it is a part of is responsible for epidermal differentiation. So, you have stem cells which are totally undifferentiated, and they give rise to different kinds of cells, right? Vitamin A is part of the process by which the epidermal cells are more differentiated. So when you have a deficiency of an enzyme that is responsible for differentiation, things can go haywire, right? It doesn't
Yes,
have to go.
even in Pathoma, they had something called like the 1517 translocation causing acute promyl acidic leukemia,
Right.
and that one having the what?
Oh, you mean the acid, the retinoic acid
Yeah, that
that you'd
one,
feed?
the retinoic
Yeah.
acid.
Okay, so you're asking me how it's related?
Yeah, like how does that phenomena cause that whole metaplasia? Like
So I don't. So what happens in this translocation? 15 and 17 translocation, right? So Abhi, do you want to chime in? Where is Abhi's knowledge? So as far as I can remember, in that lymphoma 1517 mutation, there's a prob. So that chromosome is responsible for coding for trans retinoic acid, right? And because of the translocation, there's a problem with the production of that. So when you supply it with all trans retinoic acid ATRA, it helps with differentiation. That's as far as I can remember. But anything, Abhi?
okay, and another doubt was about hypoxemia, where they explained this whole fraction of oxygen in the air, and then how it goes to that part, like that. There was this thing in Pathoma where they wrote FiO2 gives PaO2, uh, and then
So
how that whole equation, that whole I just never got that whole equation concept.
Okay, so firstly, we'll touch on that when we do the respiratory system. But if you want to touch on it vaguely, it's just that he was getting into how hypoxia and hypoxemia is sometimes used interchangeably, but they're two different things. Hypoxia is when tissues don't get enough oxygen, and hypoxemia is when there's not enough oxygen in the blood. And there are two ways that can happen, right? Either your lungs are not doing a good job of getting in oxygen, or you have problem with hemoglobin or something in the blood that is not able to carry the oxygen to the tissues. So in the initial case, when there's not enough oxygen coming in, FiO2, like suppose you're staying in a high altitude where the amount of percentage of oxygen in the air is lesser, the amount of fractional FiO2 is fraction of inspired oxygen, right? The amount of oxygen that you'll be taking into your alveoli in the first place will be decreased. So then everything from then on is everything from then on will have decreased oxygen. Your alveoli, your bloodstream, your tissues, and all that. On the other hand, suppose you have anemia and then you have decreased amount of hemoglobin. Hemoglobin is a carrier of oxygen to your tissues. So when that happens, although you have enough oxygen coming into your system, because of a lack of carrier protein, you cannot deliver enough oxygen to your tissues. So it's two different causes. The first one affects FiO2 because the amount of oxygen coming in is less. But in the other case, PaO2, which is the amount of oxygen in your blood vessels, that will be decreased when it can be multitude of causes, either because you are taking in less oxygen or because you have other problems with delivery like hemoglobin or anything else that can be affected in the chain that can decrease the amount of oxygen in the blood. We'll get into more detail about this when we talk about the respiratory, when we talk about the respiratory system physiology. Cool.
Yes.
Right, so we'll get started with today's topic. It's huge, so let's not wait for longer to get started. Today we'll be talking about the other two portions in basics of pathology. They both are absolutely critical to understand all the, like, once we start getting into the systems, you'll realize how much of it is a derivative of what is there in basics of pathology. So you just take this phenomenon and you apply to different systems. Let's say inflammation, right? You apply it to different systems and you can realize how the same phenomenon can explain so many things that can go wrong in a multitude of your organs. So once you understand this, everything else becomes a little more easier. So inflammation. Does anybody want to chime in and tell me shortly about inflammation? Maybe we can even skip through this if all of you are familiar, or it makes the job simpler if anybody can tell me a little bit about inflammation, whatever they know.
It's just a immune response. Sorry, the defense mechanism.
Right. So it's our body's way of telling us something is wrong, and something that's not supposed to happen or somebody that's not supposed to be there is in our body, right? So and then our body responds accordingly, and it tries to fight that response. Our body usually communicates using chemicals, and it has this lock and key mechanism by which it recognizes stuff we see through eyes, but each of our cell can't do the same, right? So they have pointy stuff, locks or keys on their surface that helps them attach with other receptors or other chemicals, and because of which they realize what is going on in the cell surface, and then the CPU of the cell, which is in the nucleus, can understand what is going on in the surface and react accordingly. So the second line in this presentation, which says PAMPS and DAMPS, uh, PAMP stands for pathogen associated molecular patterns, and DAMPS stands for danger associated molecular patterns. So these are just basically, suppose you have a bacteria or a virus that enters your body. There are certain parts of that bacteria on the surface of that bacteria or the virus that our body tries to recognize, that our body has a receptor for, because of which our body can understand that we are under attack, we are under siege, and there's a pathogen that has entered our body. On the other hand, let's say we have necrotic tissue, right? Ischemic tissue that has already been dead. That can. Oh, cool. It's not an issue, Saina. So on the other hand, if it's our own body and there are dead tissue, which can also be an instigator for inflammation, we should be aware of that, and there should be an immune reaction to it to help us clear the necrotic tissue. So in that case, there is something called DAMS, damage associated molecular patterns. These are again projections from our body that can attach to receptors and hence trigger reactions in our nucleus. So there's this whole pathway by which PAMs and DAMs interact with PRR, that is pattern recognition receptors that are there on the cell surface, and they are responsible for starting downstream processes. So PAMs and DAMs can be anything from maybe you're familiar with the term lipo-oligosaccharide. It is usually present in the cell wall of bacteria. It's part of the basics of microbiology. We'll cover it later, but just to be familiar with the process, to give an example, lipopolysaccharide is something of a saccharide, like a sugar chain that is present on the cell wall of the bacteria, which has a counterpart, a receptor, which is present on cells of our body. So when the bacteria enters our body and they're projecting LPS, the cells of our body can react to it, and they have a lock and key mechanism by which they attach. And after that attachment happens, there are downstream processes in the cytoplasm of the cell that then takes on the message to the nucleus to code for certain genes that will help us recruit more cells to that area. So suppose there's a bacteria, PRR attaches, there are downstream processes. There are two so wait, let me just start with the examples of the two PRRs, right? So one is toll-like receptors. Toll-like receptors are a certain family of proteins, which is the biggest sample of the PRRs that we know of. And the other one is nod-like receptors called NLR. Both of these are PRRs. They recognize the different molecular patterns shown by ischemic tissue and different molecular patterns shown by pathogens, and they trigger procedures. The pathways that I mentioned, NFK beta, JAK stat, and MAP kinase, we'll get into more details through the course of the presentation. I just wanted you to have a framework. These are three different pathways by which a signal in the cell surface can reach the nucleus. That is all you have to know as of now. All the changes that take place in the cell surface have to trigger some kind of transcriptional change, right? So as soon as a change takes place, our cell has to be aware of it, and it has to code for some proteins like DNA, which is like our genetic code, which gives rise to all the proteins, all the peptides that we make, has to know that there is a change in the cell surface and react accordingly. So whenever there's any inflammation going on, the foremost procedure that happens is our cells recognize that they're in danger, or there is some cleaning to be done, and then it triggers the nucleus to start coding for genes. And that happens through one of the many pathways. The three most common ones have been mentioned: NFK beta, JK stat, and MAP kinase. And the receptors, the examples for the two main examples that you have to remember for the receptors, toll-like receptors and NLR. And PAMs and DAMs are a very generic term. It can be anything. I've provided you with one example, which is lipopolysaccharide on the cell wall of a bacteria. As we know it, inflammation can be divided into two, acute and chronic, which is basically based on chronological order. Acute is what happens in a short time, and chronic is what happens over a long period. Before we start with the cells and the different pathways that is responsible for inflammation, we need to realize how these cells communicate. So a lot of the communication between our cells is done through chemicals, and there are different categories of chemicals, right? Amines are basically any ammonia derivative is called an amine. And some of you might be familiar with histamine, which is a chemical mediator. It acts as an enzyme. It also acts as a neurotransmitter and is responsible for certain functions in our body. And the two examples are provided are bradykinin and serotonin. So basophils are a type of immune response cells. It's part of the innate immunity, which means it is the initial response that we have towards inflammation, and it is also a very generic response. It is not instigated specifically for any pathogen, but any and whichever pathogen enters our body, it's the first response that they'll face, which is innate immunity. It just Abhi will get into more detail about that. Innate immunity basically means immunity that is instigated in a very generic pattern as the first initial response that we have to any pathogen. So basophils and mast cells are part of that type of immunity, and they secrete histamine. And when histamine is secreted, there are a lot of physiologic changes that take place. One is vasodilation. So basically the diameter of the vessel increases. And then the second one, that's the most important function that we'll be looking into for inflammation. But there are other systemic changes that happens because of histamine. One is gastric secretion. So if you're familiar with pharmacology, you will know that one of the two main medications that we use against acid production in the stomach, one is PPIs, proton pump inhibitors, and the other one is H2 blockers. The reason we do that is because histamine is responsible for secretion of gastric acid, and they are also responsible for muscle contraction. Muscle in the lungs are made up of bronchi, right? Bronchi are made up of muscles. One of the layers of the bronchi are muscles. So when histamine is secreted, there can be bronchoconstriction, which there can be bronchoconstriction. And then also, as I've already mentioned, histamine also acts as a neurotransmitter, and that is how it is responsible for the sensation of itching. Which is why, if you can recollect, antihistamines is one of the normal medications that we use for allergies and a lot of and the immune reaction, like when you get urticaria or when you get allergies, and even cough medication, right? Because of the bronchoconstriction effect, we use antihistamines for that because it gives us relief from coughing all the time. Bradykinin is another one of those mediators. It has very similar action to histamine in the sense that it does bronchoconstriction and vasodilation. And one of the most important things that you have to remember about bradykinin in terms of inflammation is that it accentuates pain. So prostaglandins are, we'll talk about prostaglandins in the next slide, but prostaglandins are another set of molecules that induce pain. But in the presence of bradykinin, it accentuates it. It acts like a synergistic effect and increases the sensation of pain in the body. Serotonin and is usually referred to as a happy hormone. We have a couple of them, but serotonin is also referred to as a happy hormone. In the CNS, it has a lot of effects. Can anybody tell me what are the drugs, first line drugs for depression that we use against depression? Anybody come across the term SSRIs, serotonin? Well, the most common ones like SSRIs maybe. Probably you guys have not reached that part yet. So what the most common antidepressants that we use these days is called serotonin SSRIs. They basically are serotonin reuptake inhibitors, which increase the amount of serotonin in at the membrane between the two nerves, because of which there's more serotonin absorbed, and it kind of acts like a happy hormone. It has a lot of effects on our mood and regulation at the level of the hypothalamus and so on. That is centrally. Its action peripherally is not very well known, but it is hypothesized to have influence on the immune system. So this is a really important slide, and the figure to the right is extremely high yield. One, because of the different mechanisms of the prostaglandins that are mentioned, and secondly, because of all the pharmacologic tiebacks that this slide has. So when we talked about the cell in the last class, we had discussed how the cell membrane is made up of phospholipids. Arachidonic acid pathway is one such, which starts with arachidonic acid, which is one of the derivatives of the phospholipids of the membrane. So there are a set of enzymes that work with this arachidonic acid as a substrate and produce a lot of enzymes in the form of prostaglandins, thromboxane, and also leukotrienes. So we'll go through the table in the right first, and then I'll tell you all the functions of all these end products. So the first one is we take the enzyme phospholipase A2. We take the enzyme phospholipase A2, convert the phospholipids in the membrane into arachidonic acid, which is our substrate for everything. Don't pay attention to the drugs that are mentioned in the slide as of now. I'll come back to it once I've explained the whole table. And from arachidonic acid, there's one of two ways the reactions can go. One is using cyclooxygenase, and the other one is using lipooxygenase. These two are just enzyme names. You just have to be aware that a lot of cells in our body possess these enzymes. And lately, they have figured out that cyclooxygenase is perpetually active. It is there in all the cells, irrespective of whether it's an immune cell or not. And it is pretty much always active. COX2 is a bit more selective, and only a few cells of our body might possess COX2. and from then on, there's a reaction that ends up the end product of which is PGH2 and prostaglandin G2, prostaglandin H2 and prostaglandin G2, and from there we go on to derive PGI2, PGE2, and thromboxane A2, which have a plethora of effects. Right, I'll start from the right. Thromboxane A2. It is the most initial reaction that we get to inflammation is vasoconstriction, which is a very transient effect. For the first 5 to 10 seconds, all the vessels in our body that is undergoing inflammation actually undergo vasoconstriction. And that is thanks to thromboxane A2, which is responsible for this action. Vasoconstriction basically means vasovessels. Constriction means shortening. So the diameter of the vessels decrease. The second one is prostaglandin A2, which is kind of like an antagonist in the form that prostaglandin E. Oh wait, not E2. So um, I'm sorry, I was talking about PGI2. I'll just finish PGE2 and then move on to PGI2. So prostaglandin E2 has a lot of effects systemically as well. One of which is increased pain sensation, which is the most important for us in today's topic. A lot of questions will ask you what are the mediators of pain sensation in our body. We have already covered one, which is the bradykinin. And the second one that you have to remember is prostaglandin E2. And the way it does it is mentioned in the left. We have different kinds of nerve fibers in our body, collection of nerves. We have different kinds of them in our body, and some of them are myelinated and some of them are unmyelinated. Myelinated just means they have this like a sheath protecting these nerves, which helps them conserve the electrical stimulus, and it has multiple uses. Usually, and it also increases the speed of transmission of the signals. And based on whether it's myelinated or unmyelinated, you can try and classify the neurons. And the neurons that are responsible for pain sensation, visceral pain sensation, are usually unmyelinated neurons, and they're called type C fibers. Prostaglandin E2 opens some ion channels in these fibers, and they give us a sensation of hyperalgesia. Algesia is pain, hyper is increase, so it increases our pain sensation by stimulating these unmyelinated C fibers. For you to remember, if you have one takeaway point, it's just that prostaglandin E2 is the specific prostaglandin that is responsible for pain sensation. And it also increases uterine tone. So during pregnancy, towards the last phase of pregnancy, suppose let's say there is so premature delivery where the mother is going into labor before she completes her term, 38 to 42 weeks. If she goes into labor before that, she or the baby can be in danger, and there are some situations in which we have to delay labor. In those situations, one of the medicines that we give is endomethacin, which is a blocker of prostaglandin E2, because prostaglandin E2 in itself increases the contraction of muscles of the uterus, and it helps to propel the baby or the ovum outside, which is why it is a part of the regimen that we use for abortion. There's a drug called misoprostol, which is an analog, which means a structurally similar molecule to prostaglandin E2. And that is a drug that we give to females when they choose to adopt. One of the drugs that we give to the females when they choose to adopt. But on the other hand, we use an antagonist, something that works by inhibiting prostaglandin E2 during when you want to delay labor. So, which is, you can understand, right? So, when you want to induce labor, you give an analog that looks like prostaglandin E2, and when you want to delay labor, you give something that is antagonist to prostaglandin E2, which is like NSAIDs, like endomethacin and all that. We'll touch on that when we discuss about the drugs. Also, prostaglandin E2 in the hypothalamus, in the CNS, is responsible for the sensation of. Okay. Okay. So, like I mentioned, the usual term pregnancy is 38 to 42 weeks. That's why moms always keep this tab, like I had you in your stomach for 9 months and all that, right? So, if the baby comes out before that, the baby is considered premature, and a lot of, especially the lungs and a lot of the other organs, are not completely developed. So, when the baby comes out in that situation, the baby cannot survive ex vivo. Oh, this is so there are different stages of labor, right? by you telling me, if you mean labor's begun as in the second stage of labor where the cervix has already ripened, gone apart, and maybe the baby's toes are outside, then you don't do anything. Then you don't delay labor. You go ahead with it. But then the initial stages of labor before that, you can when the it's when they say water broke, in layman terms, when they say that the mother's water broke and now she's leaking amniotic fluid, in that stage it's called the first stage, and that's a stage where you can still prevent or delay labor. That's when you would give drugs like indomethacin, which will help with it. Which is, indomethacin is an NSAID and it acts as an antagonist to the prostaglandin that we, yeah, there are a couple of ways that we can delay it. This is one of it. So there are so many guidelines as to when you can delay labor and when you cannot, but this is how we, if we do decide to delay labor, this is one of the ways we can do it. And also temperature. Why do we have fever when we have inflammation, right? In case of bacteria, they, just as much as us, do not like high temperatures, so our body uses it as a defense mechanism to increase the temperature, so as to kill the bacteria. But in the process, we also get a fever, which is when our temperature as a whole increases. How does it do it? In the hypothalamus, there's a normal threshold. There's a temperature at which we set, and our body realizes that that is the temperature we should be at for homeostasis, which is good functioning of all our cells in the body. But prostaglandin E2 increases that threshold, falsely making the body believe that this temperature is not enough and we have to stay at a higher temperature for our body to function, because of which our body goes through a lot of metabolic pathways to increase our temperature just to hit the threshold, and we end up having a fever. So prostaglandins are also the culprits for why we get fever. Prostaglandin I2 is kind of on the opposite end of the thromboxane molecule, because thromboxane caused vasoconstriction, but prostaglandin I2 causes vasodilation. It increases the diameter. Just one of the cardinal signs, one of the main signs of inflammation is tissue swelling, right? And the reason why tissue swells is because blood vessels come, they dilate, and they, because of their dilation and the gaps that form between the endothelial cells, a lot of the inflammatory markers are let loose between them, and they start accumulating in the tissue, which causes tissue swelling. So one of the most important points in the pathway is vasodilation, which leads to all the accumulation. So prostaglandin I2 is what helps with vasodilation. And it also decreases platelet aggregation and also decreases uterine tone. So you can see that the prostaglandins by itself have a big range, right? Some of them are pro for vasoconstriction, some of them are against it, some of them are pro for platelet aggregation, and some of them are against it. So you have to remember all of them individually to know exactly what they do. On the other hand, if we follow the lipoxygenase pathway, we end up with something called leukotrienes. And leukotrienes also have a lot of functions. To cluster them together, C, D, and E have bronchoconstriction, which is their main function. Bronchoconstriction again means bronchi are part of the system of the lungs, where you initially start with the trachea, which divide into the main bronchi, and then which divide into bronchioles, and so on and on. So, and then one of the layers of that is smooth muscle, which helps us in constricting that. And when you constrict that, you have that uneasy sensation, and so on. And you have difficulty breathing as well. So when I come into why the medications are used, you'll understand why these actions are important. LTB4 is a few of the molecules with a couple of others, which C5a and complement factors and LTB4 are important for neutrophil chemotaxis. Chemotaxis, again, our body communicates via chemicals, and there are certain chemicals that act like a GPS for our body. So basically, neutrophils are present in our blood. And once, if there's an inflammation at a certain point, how does the body know that neutrophils are needed to be recruited here? That's when chemotaxis comes into play, and molecules like this, leukotriene B4, complement factor 5A, complement factor 8A, which we'll encounter through the course of this presentation. All of them act like a GPS, and neutrophils from all over your body in the bloodstream are pushed towards, and they rush towards the crime scene, which is where the inflammation is taking place. Now, to explain about all the medications. So The one that you're all probably most familiar with is NSAIDs, which is what we use pretty much like for any kind of pain, sensation, or swelling that happens throughout the course of the day. You get a headache, use a NSAID. You get a swelling, use an NSAID. You just feel pain somewhere in your body because of muscle aches, because you play football and you're sore, use NSAIDs. For all of that, we use NSAIDs. NSAID stands for non-steroidal anti-inflammatory drugs. Non-steroidal because they do not, steroid is a certain chemical, it's a compound. Whatever has a certain structure, there's a chemical structure that pertains to what a steroid is. If you do not have the structure, the molecule is not considered a steroid. And these NSAIDs are non-steroidal because they do not have that certain structure, and they are anti-inflammatory because they block all these production of all these prostaglandins, and hence they stop us from vasodilation, they stop us from chemotaxis of the neutrophils, they decrease the swelling and all that, and they help us fight inflammation. So they are anti-inflammatory. So non-steroidal anti-inflammatory drugs. Most of you might have used it in the course, maybe ibuprofen, maybe naproxen, or diclofenac. They have fancy names from the pharmacies, but if you look at their generic name, these are what they usually are. And aspirin is slightly different from NSAIDs because aspirin actually has a non-competitive and an irreversible action on these NSAIDs. So, as I mentioned before, COX is present on most of the cells of our body, right? But there are two ways you can inhibit COX. So, what aspirin does is a process called acetylation, which is a chemical process of adding an acetyl group to the compound, to the molecule. And when aspirin does this, it does this irreversibly, which is the most important thing, because platelets, as we know it, do not have a nucleus. So they cannot adapt to change. But a lot of other cells in our body, and most of the other cells, have a nucleus. So because platelets don't have a nucleus and they cannot respond by transcribing new genes, if you block something on the level of the platelets, it's blocked forever. So when you acetylate something like the COX enzyme in the platelets, and they cannot produce thromboxane ever, they cannot aggregate. So the effect on the platelets because of aspirin is permanent. On the other hand, NSAIDs do not have this effect because they cannot give long-term inhibition to the platelets. And so in case of heart attacks, the number one drug, even before the EMS personnel arrive, the drug that people usually so even before the EMS personnel arrive, the drug that they usually use is aspirin. As soon as you know that a person is having an heart attack, they have something called chewable aspirin. They take an aspirin, which is 325 grams, 325 milligrams, and they try and swallow it, which is the initial drug that you give to any patient who's undergoing a heart attack. The reason for this is because it irreversibly inhibits production of prostaglandins in the platelets, because of which thromboxane is not produced, and hence you do not have vasoconstriction and you do not have platelet aggregation. As we know it, the number one cause for MIs is because there's a thrombi in your blood vessels, something that is constricting the blood vessels. And if it breaks down and goes further down where the diameter is even smaller, it will block the vessel and it will stop the blood supply. So you need to stop the propagation of the thrombi in your vessels, for which you need the platelets to not adhere. And for them to not adhere, you should not have these components. So you block it by giving them aspirin, which blocks the COX enzyme. That is why we use aspirin in heart attack. That's why we use NSAIDs in inflammation and sores. And acetaminophen, which is also kind of a puzzle because it only has a central action. And in the hypothalamus, it decreases the prostaglandin production. So if you remember, I told that the reason why we have an increased temperature is because we increase the threshold in the hypothalamus. So acetaminophen is good to decrease our temperature. That's why it's an antipyretic, which means it decreases our temperature, but it does not do a great deal for our inflammation. It does not decrease swelling as such. COX2, and so since COX1 is perpetually in all the cells, a lot of the scientists got together and realized that blocking that will have a lot of side effects, which it does. So they wanted something more specific, like COX2, which is present in some of the cells. So they realized, what do we find a way to attack COX2 in specific so that all the side effects will be much more limited? That's when they came up with drugs like celecoxib, which is a COX2 inhibitor, which has a much more specific action. Now, if you look to your left, we'll try to understand why the side effects of NSAIDs happen and why the effects of NSAIDs as such happen. I've already mentioned the cervical ripening effect and why we use it in pregnancy. And the other one is oh, okay. One second. So acetylation prevents platelet. Yeah. So acetylation blocks COX enzyme, and COX enzyme is responsible for prostaglandin production. If you block COX, no prostaglandins and no thromboxane. And when there's no thromboxane, you don't have aggregation. Yeah. So it has an indirect effect, but basically that's what happens. Cool. One sec. Yeah. Can anybody tell me what is the number one toxicity for NSAIDs? And then we can move on from non-steroidal antibiotic.
Liver
What is
damage.
it? Liver, that's for acetaminophen. Acetaminophen's number one toxicity could be liver damage if you overdose on it. But how about NSAIDs, ibuprofen, and all that?
GIT toxicity maybe.
Exactly, yeah. So as it's mentioned that cyclooxygenase, it plays in. Yeah, so my question was, what is the most common side effect faced by people who consume NSAIDs for a duration of time, for a week or more than that? And Sayana correctly mentioned that it's GI toxicity. The reasons can also be explained by looking into this table, is because prostaglandins are also responsible for secretion of mucus and decreasing acid secretion in the stomach. So when you block the prostaglandins, there's decreased mucus production, there's increased acid production, and it all culminates in injuring the cells in the lining of your stomach, which can result in an ulcer. That is why some people prescribe drugs like PPIs while giving NSAIDs for a long term. And a lot of the conditions like rheumatoid arthritis, where there's chronic inflammation and people abuse NSAIDs, they develop a lot of gastric ulcers or duodenal ulcers. And that's when, you have to be wary of it when you prescribe NSAIDs for a long time. One second. Yeah, so if you understood all that, it's really simple to derive what are the 5 cardinal signs of inflammation. They are Latin terms: rubor, calla, tumor, and dolor, and loss of function. So rubor and calla basically mean redness and warmth. More blood, more red pigment. More blood, more hemoglobin, which is a red pigment, so you look redder. And obviously you look warmer because the blood is in itself is a warm fluid. So it's self-derivative that anytime there's inflammation and there's vasodilation because of the inflammation, there'll be more blood flowing into the tissue, which will cause it to be erythematous, which is a fancy $10 word for red. And also it's warm because blood is a warm fluid. And you have to remember, like we mentioned, the mediators, histamine, prostaglandins, and bradykinin. These are the main mediators by which vasodilation takes place, and hence they are the ones responsible for the redness and the warmth of the tissue. So when vasodilation takes place, there's also another phenomenon that is taking place. So this is the diameter of the vessel, right? So when you vasodilate, the diameter increases, and also the individual endothelial cells contract. When that happens, the cell adhesion, there is an adhesion between all the cells, right? And when they contract, the gap between all of the cells increase. So not only is there vasodilation, there's also a gap between all the cells. That's when all the neutrophils, macrophages, and all the immune cells, along with a lot of water and osmosis, because of osmosis and all that, there's tissue swelling. So tumor is because of not only because of the vasodilation, also because the endothelial cells, the cells that line the blood vessels, they contract. And because of a lack of adhesion, a lot of stuff escape from your blood and it accumulates in the tissue, which causes the swelling. And dolor is pain sensation. And you have to remember that the 3 mediators, most importantly, PGE2 and bradykinin, are the ones that sensitize our unmyelinated C fibers, which are a type of nerve bundle, and that is what is responsible for the pain. Okay. Yeah, this is just an example of a condition like cellulitis, where there's an infection because of a bacteria, and that has led to inflammation. And as you can see, it shows all the cardinal signs. It is red. It is probably warm, but we cannot make it out. But it is surely swollen, and the patient is surely in pain. And because of all this, she cannot use her leg, which is lack of function, loss of function. So those are the 5 cardinal signs of inflammation that you have to remember. So when inflammation takes place, there are different acute phase reactants, which are basically proteins made in the liver that are increased and decreased in differently. Uh, which sorry, yeah. So during acute inflammation, there are a lot of proteins that are made in the liver. Some of them, so the production of some of the proteins increase. On the other hand, the production of some of the proteins decrease. The most beautiful thing is that you can apply logic and figure out why most of these things happen. And to understand the first part of that, you have to realize how iron moves through our body. And for that, uh, you refer to the diagram in the right. So as soon as you consume it, iron is there in the stomach. It's absorbed in the intestines. It goes into your the cells that line the intestinal epithelial cells. And after the iron moves in there, using so when iron comes out of the cell and into the blood, you need a port. The port is called ferroportin, which acts like an ion channel that secretes iron from the cell into the blood. And once the iron is in the blood, you need something to carry the iron, the transporter, which is transferrin. So iron moves in the blood with transferrin. It goes into the bone marrow where it joins with the erythrocyte cell, which is the RBC, and helps in the formation of hemoglobin. For hemoglobin you need iron in the center, and that's how it helps binding with it helps to bind with the oxygen. So you need iron in the center. So from the blood, it can go to any part, mainly the bone marrow, where you need it for the production of RBCs. And from there on, it continues its journey from the bone marrow back into the blood, but now it's inside RBCs. And it goes to the spleen, where RBCs is like the graveyard for RBCs, because all the RBCs that have reached their limit 120 days or are in some or the other way non-functional because of their structure or physiology or anatomy are consumed by the macrophages that is there in the spleen. And after which the iron is separated from the hemoglobin and it's taken down again into the macrophages. So if you understand that, you can realize why some of the things that happen during inflammation do happen. So bacteria need iron for their metabolism. Just like us human beings, bacteria have, for them also iron is vital. So again, our body, thinking it's too clever, puts into motion a few reactions that takes place to decrease the amount of iron available for the bacteria. So think about it logically. What are the things that you would decrease if you want the bacteria to have lesser iron? The first thing you would do is you would decrease the amount of bacteria and the amount of iron in the bloodstream. So the way our body does it is it decreases the amount of transferrin. When you decrease the amount of transferrin, you cannot transport iron, and hence there's lesser iron in the blood. The second thing it does is it increases the amount of iron storage inside the cell, and that it does by increasing ferritin. So transferrin decreases, ferritin increases. Thirdly, there is a molecule called hepcidin, which is responsible for inserting these ferroportins into the cells, which is responsible. Ferroportin, like I mentioned before, is responsible for moving iron from the cells into the blood. So if you have hepcidin that is controlling this reaction and hepcidin is preventing the insertion of ferroportin, iron automatically cannot move from the cell into the blood, and hence low iron in the blood. So it increases hepcidin, which decreases ferroportin. It also increases ferritin, both of which, hepcidin and ferritin, increase the iron in the cell and decrease the iron in the blood. And transferrin, on the other hand, is decreased because it increases iron in the blood. Maybe I told iron in blood too many times. Is anybody confused? Is it clear?
Can you
Yes.
explain it again?
Yeah, sure. So basically, our body is trying to fight the. So bacteria need iron. We don't need bacteria, so we are trying not to give iron to the bacteria. The way our body does it is it increases anything and everything that increases iron in the cell and decreases iron in the blood. The things that increase iron in the cell Exactly. So we are trying to deplete iron in the blood. So the way we do that is by increasing the amount of iron that you store in the cell. And the way we store iron in the cell is using a molecule called ferritin. So we increase ferritin. The next thing we do is we prevent its release from the cell by increasing hepcidin, because hepcidin codes for ferroportin, which is there on the cell membrane to help the iron move from the cell into the blood. So when we increase hepcidin, it decreases ferroportin, and there's decreased iron movement from the cell to the blood. So we've increased two things. We have increased the storage form of iron, which is ferritin. We have decreased iron leakage from the cell by increasing hepcidin. Thirdly, we also decrease transferrin, because that is what transports iron in the blood. Is that better?
Yeah, understood. Thank you.
Yeah. And then lastly, there's haptoglobulin, which is how we. So usually RBCs contain the hemoglobin, but when RBCs leak into the blood and there's free hemoglobin, I mean, when hemoglobin leaks into the blood and there's free hemoglobin, anything that leads to intravascular, like anything that damages the RBCs while it is in the bloodstream, can cause hemoglobin to leak from the RBCs. And when that happens, there's a molecule called haptoglobulin, which binds to this hemoglobin and takes it out of the bloodstream. We also increase this because again, hemoglobin contains iron and we don't want bacteria to have access to the iron, and also because the free hemoglobin that is there in our bloodstream can cause reactive oxygen species. This is a callback to our first lecture. Anytime there's reactive oxygen species, there's free radicals. Free radicals cause damage, lipid peroxidation, and protein breakage, DNA breakage, protein modification, and lipid peroxidation. So ROS, yeah. So to avoid all that humbug, we have haptoglobulin, which clears the hemoglobin from the bloodstream. So as a whole, you have to remember ferritin, hepcidin, haptoglobulin increases, transferrin decreases. Right. So the other acute phase reactants, fibrinogen. Some of you might be familiar with it. So we have different pathways, cascades that are in place for us to coagulate blood, and it all culminates in converting fibrinogen to fibrin. So what fibrin does is that basically it helps bind between two platelets. So if you want to form a clot, the initial clot is formed just by platelets. It's called the primary plug, and when that happens, you need the platelets to bind with each other. Fibrinogen is converted to fibrin, which acts like the glue, like a bridge per se, which binds the two fibrin molecules together. And so you need to increase that, right? Because there can be a rupture of blood vessels, or you're trying to contain the spread of the pathogen. The bacteria has infected one part of your body, but you don't want it to infect the other. So you have to try and contain it. And anytime you want to contain it, form some sort of, like a block, you need fibrinogen to increase, because of which fibrin will increase and form the block. Secondly, serum amyloid A. So I tried looking into why we need it in the first place. All that I got was that it is hypothesized to induce negative feedback. So it realizes that fever, although it's harmful for the bacteria, can also be harmful for us. And platelet aggregation can also be harmful for us if it is unregulated. So it acts kind of like a negative feedback, but again, it's not very sure. It's only a hypothesis of why we need it. But we know very well what will happen if it accumulates, which is amyloidosis. So amyloidosis is basically a branch of diseases that take place when protein is accumulated in the extracellular space where it is not supposed to be. So it basically is a umbrella term for all the diseases. It can be multitude of reasons, but if protein accumulates in the basic pathology of amyloidosis is protein accumulation in the extracellular space. So serum amyloid A is the reason by which a lot of the chronic inflammatory diseases like inflammatory bowel disease or rheumatoid arthritis and all that can cause amyloidosis, because when there's chronic inflammation, there's a lot of serum amyloid A, which then goes on to accumulate in the extracellular space and lead to the amyloidosis. When we discuss amyloidosis as a pathology in itself, you'll realize that serum amyloid A was one of the proteins that can accumulate. C-reactive protein is also another important acute phase reactant. If you've yourself been affected by an infection and gone to the lab, one of the initial tests that they do for all the patients is ESR. It's called erythrocyte sedimentation rate, and the other one is C-reactive protein. All of us have a normal level, but during inflammation, this molecule increases exponentially, and that is how the labs realize that our body is inflamed. So that is one of the most initial tests we do. And the physiologic action of the C-reactive protein, the reason why it increases during acute inflammation is because it acts as an opsonin. So opsonin is basically, again, uh, all cells can't see with their eyes. So you need something. So you need kind of like a tag. What opsonins do is they tag these pathogens with a certain, like in the airport, there's this luggage that they mark with an X because there's something dangerous inside. They just don't know what, but there is something dangerous inside. So whenever it's marked with an X, the security, you have to go through extra security to get that luggage out of the airport. Kind of like that. The C-reactive protein marks the pathogen with a certain thing on their surface, so that our phagocytes, our cells that are responsible for clearing these pathogens, can recognize them better. So it basically helps in phagocytosis, that is, lysis of the pathogen that has entered our body. So it marks the pathogen with a certain molecule, which helps our immune system recognize it better and digest it better. So you need to remember C-reactive protein because it has a very good clinical tie-up. Is the fact that that is a enzyme, that is a molecule that we measure to know whether our body is undergoing inflammation or not. Procalcitonin, again, some of you might remember calcitonin, which is produced in the thyroid, in the medullary cells of the thyroid gland, but this is different from that. And the most important factor that you have to remember about procalcitonin is that this is one of the ways in which we can know whether the inflammation in our body is due to a virus or due to a bacteria. Again, it's not been elucidated as to why this is the differentiating factor, but they say that bacteria induce more neutrophilic leukocytosis, meaning it increases the amount of neutrophils majorly with respect to the other cells. Neutrophils are the ones that is instigated majorly, and these neutrophils secrete procalcitonin. So it is not a very sensitive test. It is not a very good method to realize whether we are affected by a bacteria or a virus, but it is one of those things that can help us at least give us direction whether the pathogen is a bacteria or a virus. So when you go with, let's say, sinusitis or something like that to the doctor, and the doctor is not sure whether the sinusitis is caused by a virus or a bacteria, he can theoretically order a procalcitonin test, and depending on its levels, which is increased much more in a bacterial infection rather than a viral infection, the doctor can get an idea which one is increased. Lastly, albumin. So albumin is the most abundant protein in your body. So obviously, a lot of the amino acids go into its making. So when you want to increase all the stuff that I mentioned before, right? Fibrinogen, SAA, CRP, procalcitonin. If you want to increase all of that, you need raw material. And this raw material is stolen from the liver, which is responsible for making albumin. So if you're going to take all this raw material to make stuff like fibrinogen, SAA, and CRP, automatically you have to decrease the production of albumin. So in order to conserve these amino acids, we decrease the production of albumin. So please remember, transferrin and albumin decreases, ferritin, hepcidin, haptoglobulin, CRP, SAA, fibrinogen, and procalcitonin increases. Yeah, so kind of imagine it like a war between the immune cells in our body and the pathogen, and all these horsemen that we've just mentioned are the ones that initially pose an attack to the pathogen, and then we move on from there. Yeah, we will talk more about acute inflammation. Oh, that's a long conversation. Guys?
Yeah, okay.
Yeah, okay. Guys, let's start with acute inflammation now because this is a really long topic. And yeah, let's see. Acute inflammation. So, like Ashwin had mentioned, inflammation is basically the body's response towards any pathogenic factors. These pathogenic factors can be trauma, infection, necrosis, or maybe the presence of like a foreign body inside your body. That's what foreign body means. Then main signs of inflammation, like Ashwin said, it was swelling and heat. And this swelling is basically because of the blood vessel dilation that we saw because of some of the prostaglandins, prostacyclins specifically. So these cause edema. So once the blood vessels become leaky, so not just the inflammatory cells go towards the point of inflammation, but also the plasma proteins start leaking into that area. So not just plasma proteins, then with plasma proteins they increase the oncotic pressure in the extracellular space, so they'll pull more water. It will also cause some more swelling. And neutrophilic infiltration, which is the main purpose behind having leaky capillaries. And this event in acute inflammation occurs within minutes. So as soon as, suppose, you get a cut in your hand, or once there's a bacteria that enters your body, the whole body starts responding basically by the secretion of chemotactic factors that Ashwin mentioned: leukotriene B4, C5a, IL8. These are important things which we'll mention that later, but just keep in mind. So these chemotactic factors call up the neutrophils to that place, and the neutrophils then begin their work. Neutrophils are basically immune cells, and their main role is to clean up and destroy the bacterial invasion, bacterial or whatever the body deems not where it's not supposed to be. So acute inflammation, the main role, like the reason why our body does this is, like I said, elimination of the pathogenic factor, which can be any one of them. It just doesn't have to be bacteria. And also once that war or that battle, like Ashwin mentioned, happens, so there'll be so much cellular debris and necrotic material, because if you leave it there, there's a chance that that can get reinfected, because necrotic material is a good nidus for more infection, so you need to get rid of that. And that's why acute inflammation, the neutrophils, macrophages specifically, sorry, macrophages come up and they clean up the place. And if the tissue does have stem cells, so you can reform the dead area based on if they have stem cells or not. So things like cardiac myocytes, skeletal muscles, and nerve cells, which I mentioned in the first class, they do not have stem cells. So if they have an injury, it'll just be repaired with fibrosis and fibrosis basically, and scar tissue formation. So if someone has a heart attack, okay, then acute inflammation takes place, the neutrophils goes there, clean up the dead tissue. Because of the lack of blood supply, there's dead tissue, so that is the stimulus for inflammation here. Then neutrophils get in, then neutrophils clean up that area, then macrophages go eat the cellular debris, and then eventually macrophages and other fibroblasts will initiate the tissue repair uh, by placing scar tissue. You cannot, the lost heart cells are lost. So that's why people say in a person with a heart attack or a MI, time is muscle, because the more time you delay, the more blood supply is cut to the heart, and it ends up being more your heart tissue that's lost. So it'll just be replaced with scar tissue in the end. This is a transient response. Usually, acute inflammation usually lasts days to weeks, and that is if this is a appropriate response. There are things that can happen in our body which we'll look at later that can trigger this response even without the presence of trauma, infection, necrosis, or it might have been present, but then it didn't end up aborting, because after the tissue repair, the inflammation needs to subside. But what happens is, maybe that stimulus is there, maybe there's a mutation, or there's some genetic condition like an autoimmune disease. This inflammation just keeps on going on and on and on. So as you know, Ashwin mentioned that all these acute phase reactants like serum amyloid or fibrinogen, all these are consistently elevated in these people, and they by themselves eventually cause another series of damage. Acute inflammation, again, it involves the innate immune system. I'll discuss what the innate immune system means, but what you need to remember is innate immune system is one of the first mechanisms of defenses that we had developed. So it's like a non-specific attack. It does not, it's not like antibody production where okay, you form antibodies against this virus, maybe coronavirus, or maybe antibodies against some bacterial infection. In innate immune system, there's nothing. It just recognizes these pathogen associated molecular patterns that Ashwin talked about, PAMPs. So those lipopolysaccharides, or there are other cell wall proteins that our innate immune system has over the years, I mean over billions of years of evolution, has recognized dangerous, and they respond to it. But they're not specific to one bacteria. It's something that all of those bacteria will have, or a certain group of bacteria will have. Anyway, we'll look at it. And then acute inflammation, all the 5 cardinal signs of inflammation will be present because of this. So we have 2 different types of immune system. Just a small recap because we didn't cover immunology yet. So innate immunity involves these types of cells, and these types of cells are basically non-specific, attacking the pathogen. But as you see, there's adaptive immunity. So these are the first responders. Then over time, then our body will eventually cause the adaptive immunity to take over, and then you will produce specific antibodies against the pathogen, or your T cells will recognize them if it's a viral infection. Things like that will happen over time, but the first thing that happens is innate immunity is the first responder, and that is what happens in acute inflammation. So as you can think about, so if acute inflammation is mainly caused by innate immunity, then chronic inflammation, there will be involvement of the adaptive immunity, because chronic means it's happening over time, and when time goes by, your adaptive immunity takes over. So that's why in chronic inflammation you'll see more lymphocytes and those types of cells. In innate immunity, you will see in acute inflammation, which involves innate immunity, you'll see neutrophils, mast cells, eosinophils, basophils, dendritic cells, macrophages. These can present antigens, and neutrophils will do the killing. And NK cells, they're kind of like a connection, but they can do both adaptive and innate immunity. Basically, they can be triggered by both types of reactions. So here we see a histological slide. So all these red marks you see here are blood vessels. I mean blood cells, RBCs, and this is a blood vessel. So as we mentioned before, so Ashwin mentioned those leukotriene B4s. Those are chemotactic factors for neutrophils. So neutrophils are supposed to reach that area where the inflammation is happening. Suppose it's somewhere over here. So neutrophils need to get out of the bloodstream and reach there. So as you can see, these are neutrophils. All of these cells with multiple nuclei. Usually neutrophils have hypersegmented nuclei. So these cells, which what they do is first they marginate, and then they slowly go through those leaky capillary walls and enter the site. And then based on the concentration gradient of the chemotactic factor, maybe C5a, IL-8, or LTB4, they would go towards that concentration gradient. So we'll look at all the steps, which is very important. It's called leukocyte extravasation, and we'll look at how that works a little bit later. But this is the actual histological slide of this process. So yeah, innate immunity. So just a small detail about innate immunity. What are the players involved in this? So as you can see, once a pathogen affects an area, they have these pathogen associated molecular patterns. So it's a generic pattern that's probably present in bacteria and like lipopolysaccharides, and we have pattern recognition receptors. This is a general term for multiple receptors that we have, like Ashwin mentioned, toll-like receptors, NLR, nod-like receptors. These can recognize these pathogen associated proteins, and based on that, what happens is they will take up antigens from lipopolysaccharides and the pathogen, and these APCs, which are antigen presenting cells, they will degrade it and then present it. They'll present it to T cells and other macrophages and polymorphonucleocytes, which are neutrophils, which then activate them based on the cytokines released. I'll go into detail, but I just wanted to give you an overview of how this works. So toll-like receptors are one of the main things involved in this. Uh, Sometimes even this innate immunity can be triggered by your own cell. So this usually happens in like systemic lupus erythematosus. What happens is there are some antibodies that might be formed, or your complement might be attacking your own cells. So what happens is those cellular proteins get released, and a cell also needs to respond to cellular damage, not just pathogen damage. So what happens is these cellular proteins, they also are recognized by these toll-like receptors, because once what is supposed to be inside the cell is recognized outside, then the cell knows there's something wrong and they should respond to it. So it's like a danger signal. So strangers and dangers is what the innate immunity responds to. These uh, these damaged proteins will be again presented, and then it will still again activate T cells, macrophages, and neutrophils. So we have a lot of toll-like receptors, multiple classes, and as you can see, each toll-like receptor, they recognize different types of proteins. So those pathogen associated proteins like LPS, flagellin, because flagella is something most bacteria have to like move through the medium. So that is also one thing we recognize. And double-stranded RNA, ssRNA, CpG which is methylated DNA. So what happens is these are the ones, the danger associated ones that are released from our cell, because RNA, single-stranded RNA, we might release from our cells, or this might be from viral infection. Again, it doesn't matter. So we recognize them. Then we have this intracellular signaling. So once these bind to this area, the signaling cascade is triggered, and one of the main things is MyD88. MyD88 is part of a complex that eventually triggers transcription of genes that are involved in inflammation. So interleukin 1, all these inflammatory cytokines like interleukin 1, IL-2, interferon gamma, TNF alpha, all these are stimulated by MyD88 to produce, and they will what do you call, sustain the immune reaction. And once the stimulus is gone, then the MyD88 won't trigger the gene transcription, and eventually the inflammation would die out. So you can see that, when there's persistent triggering of these receptors, then it will lead to a continuous inflammatory response without it dying down. An important thing that very frequently comes in USMLE exams is this transcription factor called NF kappa B. So Ashwin also mentioned about NF kappa B. NF kappa B is one of the main molecular main molecules that are responsible for the transcription of pro-inflammatory cytokines. So any kind of inflammation that is happening, that means NF kappa B goes to the DNA and it causes transcription of RNA that is involved in inflammation. So as you can see, if there's anything wrong along this process, then we cannot respond to the pathogens or whatnot. So there's a specific condition called MyD88. What happens in MyD88 patients, as you can see, their innate immunity would not function, because all the receptors used in innate immunity right here, they require MyD88. So if this is not present, you won't get an inflammatory response to these pathogens. So that's what happens in these patients, and they have a very decreased survival compared to normal people, because by 10 years, 50% of the patients who were involved in the study had died, and that is mainly due to bacterial infection. And the only way to control this, there's no supplement for MyD88 or anything. What you can do is, once they get an infection or they have signs of an infection, then you need to treat them early with antibiotics, sometimes prophylactic antibiotics as well. So this disease is not important, but I just mentioned it because it shows a clinical correlation of how, if something goes wrong in this cascade, how it can show up in as a clinical manifestation. This arachidonic acid pathway, Ashwin went in very detail, and it is also a very important player of in acute inflammation. This is a small table I got from Amboss library, and it mentions the exact details regarding what each of them do, and Ashwin went through them and pretty well. So I'm not going to cover this right now. If you want, this will be in the lecture slide, so you can use this for your review. Next, we have something called an inflammasome. So inflammasome is basically something that triggers inflammation. So these NLRP, which is a intercellular innate immunity. NLRP is part of the innate immunity, and in innate immunity, you need to form an inflammasome to respond to the pathogen. So by response, I mean produce pro-inflammatory cytokines like IL-1. IL-1, which we'll look at later, produces fever, and IL-18, like it sustains the inflammatory reaction. So what happens is this inflammasome, no need to forget about all these names. What you just need to know is inflammasome is a complex, and it will end up producing IL-1 if it's triggered, and it will lead to pyroptosis. So pyroptosis is how our body, like Ashwin mentioned, if we have fever, how we plan on killing bacteria. So these will increase the body temperature, IL-1, and this can eventually lead to pyroptosis. So this is a syndrome. It's called familial Mediterranean fever, and familial Mediterranean fever is a chronic recurrent fever syndrome. So what happens is these guys have a gain of function mutation in the inflammasome. So even without the pathogen, this inflammasome is activated. So they keep producing IL-1, IL-18, thinking that okay, the body needs fever. It needs to there needs to be pyroptosis, but the it's an inappropriate response. And so these patients, they present with a lot of signs and symptoms of inflammation. These signs and symptoms, I'm just mentioning it, but you don't have to know them for now. This is serositis, pleuritis, synovitis. So inflammation of any surface of your organ, they'll probably have it, and they will have recurring fever. So these are called periodic fever syndromes, and it's a rare disease, familial Mediterranean fever, but there have been questions on the USMLE about FMF, so it's good to know. And basically, it's a defect in the gene that codes for one of the components of an inflammasome. Yeah, and the reason it's called familial Mediterranean fever is because it is usually seen in the Mediterranean population. So in Middle East and Greek, in that area, and it's an autosomal recessive condition. It's familial because it is usually seen in population where there's a high rate of consanguinity or inbreeding. So even in Ashkenazi Jews is possible to see some of it. So these are the signs and symptoms. Like I mentioned, you don't have to know, but this is basically the result of chronic IL-1 stimulation, which is an inflammatory cytokine. So all the surfaces in your body, like around your heart, you have pericardium, so you'll have pericarditis. Around your thorax, you have pleuritis. Joints are covered with synovium, synovitis. Abdomen, we have peritoneum, peritonitis. So even the testicles have a layer, so you can have inflammation of that. And so basically they're just an inflammatory mess, and the treatment for this obviously is to reduce the inflammation. So any of the drugs Ashwin mentioned before, or something like corticosteroids, NSAIDs, those are the primary modes of treatment. And recently there are things that can block cytokines like IL-1 blocker or things like that that would directly block the pathogenesis. This is another group of syndromes. I'm not going to go through them, but I just wanted to mention that again, anything that goes wrong in the process of the inflammasome, which is the production of IL-1 and IL-18, will end up causing recurrent inflammatory syndromes. These are nice ones to know. You can have a look at it. Have a look at them at the lecture slides. So we'll move on to how acute inflammation, how the pathogenesis, step by step, how it works. But before that, the main mediators of acute inflammation, which Ashwin has already mentioned, are toll-like receptors, arachidonic acid metabolites, neutrophils, the primary responders, eosinophils. If there is pre-existing antibodies, because antibodies are not formed at the time of acute inflammation, and some of the other stuff. So this is how acute inflammation looks. It's basically you'll have an injury. Eventually, there's all these mediators that end up at the site of inflammation because of all the chemokines that are released, chemokine and the toxin, and that inflammation eventually will end up in healing, the healing process, depending on if there is stem cells or not, and fibrin collagen deposition, and there's wound healing. We'll take a look at it step by step. So first you have an injury. So the first response to an injury, like Ashwin mentioned, is a transient vasoconstriction. So even before vasodilation happens, which is how all these inflammatory mediators end up in the extracellular space, there's a transient vasoconstriction stimulated by, can anyone remind me because it was mentioned before? The first reason why there's vasoconstriction in acute inflammation, there's a certain molecule. Yeah, thromboxane A2. Thromboxane A2 is the initial mediator that causes vasoconstriction, and then eventually the prostaglandins get produced and there's vasodilation. So the main reasoning behind this is, if you think about it, if there is some damage to the area, our blood vessels see the damage and they want to respond to it fast. The smooth muscles contract, causing vasoconstriction because of the thromboxane that's released because of endothelial damage. But then eventually the prostaglandins start producing and that area becomes, the blood vessels dilate. So if there is a dilated blood vessel, there's increased blood flow because the diameter is increased. But at the same time, if there's dilation here and there's usually there's a smaller area here, and this area close to the site of injury is dilated. So what happens is, usually in a tube there's laminar flow, but because there's dilation of this tube and this area, the blood sees an increase in area, the velocity slows down. So from high velocity to slow velocity, uh, once the blood is flowing, it becomes a turbulent flow. This turbulent flow creates a stasis. So this is one of the body's intelligent mechanisms to stop all these things that are coming to this area, to slow them down, and so that they can reach that area better. So this is a pretty smart way that our body does. So it causes turbulent flow. All the inflammatory mediators like neutrophils, macrophages, they get stuck in this area because there's turbulence, and then eventually they'll hit the sides, and then they will move towards the higher concentration gradient of the chemotactic factors. Yeah, we have vasodilation, and that is induced by not just prostaglandin, as we saw, histamine, serotonin from platelets, bradykinin, and nitric oxide. So if there's direct endothelial damage, endothelial cells usually have nitric oxide, and it's a vasodilator. So you might know from like anesthesia that nitric oxide is also used as an anesthesia, and one of the side effects of that is low blood pressure because it dilates your blood vessels. Yeah, this is step one. So hemodynamic change, what happens? First you have vasoconstriction by thromboxane A2, then followed by vasodilation because of all these mediators, and that causes stasis and increased blood flow to that region. So this is what I was talking about. So it's coming straight, but then eventually once there's decreased velocity here, there will be turbulence, and this will allow them to reach to whatever the site they want. Then to reach the site they want, there needs to be a gap between the cells so that all these inflammatory media neutrophils can penetrate and reach that site. Because as you can see, endothelium is not leaky, that's why we don't leak blood. But during inflammation, we have mechanisms in place so that we can loosen these tight junctions. Cells are connected to each other by tight junctions, we can loosen them, and then that would allow all these neutrophils to transmigrate through the cells. So how do our cells increase vascular permeability? Again, there's similar molecules: histamine, serotonin, bradykinin, and leukotriene C4, D4, and E4. So you might be wondering, do you have to know all of these chemicals and their mechanism? I think you do, and it would be helpful later on as well regarding other pathologies, like in leukotrienes are also involved in asthma and bronchoconstriction. So it'd be helpful if you know all of the functions of the mediators that we talked about today. But anyway, so what happens is these mediators, they cause retraction of the endothelial cells. So if the endothelial cell is normally big, what happens is there are smooth muscle cells around it that can cause the retraction of individual cells. And also we release something called metalloproteinases. So these metalloproteinases, they go and they degrade the space and degrade the structures in between, like tight junctions, or if there's some connective tissue, they would degrade the basement membrane and allow the neutrophils to go through them. Endothelial injury. Sometimes the injury itself, so if you have a deep enough cut, there might be just the blood vessel itself is damaged. So that in itself is enough for all these mediators to leak through that area. But this damage might lead to further problems because you have less blood supply down the. So if you have a cut in a blood vessel, and there will be less blood supply uh, down the line, yeah, down the line, so that can lead to necrosis of further material that are present ahead of it. Then a leakage of plasma content. So once there's vascular permeability, all the contents of the plasma, they leak into the area of the injury, and they cause edema. And also the immune cells also make use of this to go through and reach the site of injury or infection. So these are usually the cytokines that are involved, but you don't have to know them because separately in immunology we'll cover the functions of each cytokines. But the good things to keep in mind is IL-1 and TNF alpha. So TNF alpha is one of the first things that stimulates this endothelial contraction and promoting vascular leakage, and IL-1 promotes fever, as we saw before, fever and recruitment of inflammatory cells. Then leukocyte extravasation. So once now we have everything set up, so there's holes in the blood vessels and there's decreased blood flow, so we have collected all the people that needs to go to the site. So how do these leukocytes end up going? Because it's not like they have a mind of their own, so they go through a process, and this process is what's called leukocyte extravasation. We'll look at it in details, but just keep in mind that this extravasation only happens in post-capillary venules. So these post-capillary venules are the ones that end up being leaky and allow the leakage of all these leukocytes, predominant neutrophils, to the site of the injury. Then once neutrophils reach there, they just do their function, which is phagocytosis of the bacteria, or if there's a foreign body, phagocytosis of that, if there's necrotic material, phagocytosis of that. And it would then, using its phagolysosomes and the lysosomal enzymes, the hydrolytic ones that are present, it would degrade that material. And yeah, so these are the so acute inflammation. So once neutrophils reach that area, they degrade the uh, pathogen or the cellular debris present, and eventually it should either come to a conclusion, or there are different outcomes that can happen. We can look at the different outcomes. So there's one outcome you can have is a persistent acute inflammation. So the acute inflammation happened, but there's nothing that's stopping it. So usually what happens is, over time, the inflammatory signal, maybe the signal that's caused all this neutrophil migration and all these chemokines, will die down, and it will result in the resolution of acute inflammation. But for some reason, usually because of the presence of IL-8, inappropriately of course, it can lead to the acute inflammatory response being present. But the thing is, it does not progress to chronic inflammation. So while we did mention that acute inflammation and chronic inflammation are just time based, but it cannot be called chronic inflammation if there is no lymphocytes present. So even if this acute inflammation is there for like 6 months, you cannot call it chronic if there's no lymphocytes and the adaptive immunity is not involved. You cannot call them chronic inflammation. That's one thing. So there will be persistent acute inflammation. Then again, serum amyloid protein will increase high risk of amyloidosis. Um, and many other problems. Resolution with regeneration. So resolution with regeneration happens, like I mentioned, in tissues that have stem cells. So if the damaged tissue can be does have stem cells, so they can repopulate that area, and there will be complete resolution, most probably without even knowing why there was a damage. But in when there's a lack of stem cells, then you have resolution with scarring, and the original tissue will be replaced by that fibrotic scar. And the mediators for each of these are also kind of important to know. So resolution with regeneration, you have IL-10 and TGF beta. These, so before we saw something called pro-inflammatory cytokines. These are things that are called anti-inflammatory cytokines, and once they start getting upregulated, they stop the inflammatory process and make the process proceed towards wound healing. So TGF beta is a really important factor in terms of wound healing, and Ashwin will talk about that in a bit. But just remember, IL-10 and TGF beta are anti-inflammatory cytokines. So obviously, if our body has pro-inflammatory, our body also has anti-inflammatory to counteract the acute inflammation. But when these are not present in the right time, or if they are not upregulated, sometimes the inflammatory process will keep on going. If IL-8 is present, it probably can inhibit one of them and maybe cause persistent acute inflammation. Again, resolution with scarring. Scar tissue, fibrotic scar tissue is mainly regulated by TGF beta, like I told you, during the wound healing process, and also FGF2. FGF2 is called fibroblast growth factor and platelet derived growth factor. So these two factors, which we'll see in wound healing, but are really important in terms of scar tissue formation. So fibroblasts are like the cells that secrete collagen and they lay down collagen. Platelet derived growth factors are also important in the angiogenesis and other types of healing. Abscess formation. So, okay, you can resolve, or maybe there might be so much necrosis that our body cannot handle it. So, what happens is, what our body does, it forms a fibrous capsule, like it lays fibroblasts around that area and contains that necrotic and infected area within a cavity, and this cavity is called an abscess. So usually in the middle of an abscess is like the war zone, where the acute inflammation is still happening. Neutrophils are fighting against the bacteria. There's pus formation. Pus is usually dead white blood cells, dead bacteria or fungi, and there will be tissue necrosis because cells also die in the process. So this is abscess formation, usually mediated by obviously the inflammatory cytokines, pro-inflammatory cytokines, the most common ones, IL-1 beta and TNF alpha. Chronic inflammation, again, we'll look at it later. So these are the outcomes. So which acute inflammation can end up in any one of this. So acute inflammation can eventually turn into chronic inflammation if the causative factor is persistent. So what happens in chronic inflammation? The stimulus is still present, and it causes the macrophages and the antigen presenting cells to involve the adaptive immunity. So before it was just the innate immunity, now the adaptive immunity is involved. Then we have T helper cells coming in. Then there are certain cytokines that are produced like IL-1, TNF alpha, IL-12, IL-6. These cause activation of the CD4 T helper cells, and then eventually infiltration into the affected tissues, and then T cells will kill according to their mechanisms. So just a summary slide. What are the events that happens in acute inflammation? So initial transient vasoconstriction, then there's persistent progressive vasodilation, again mediated by prostacyclin and some of the prostaglandins. Then the local hydrostatic pressure is elevated because there's vasodilation. If there's increased vessel diameter, then there's more blood, then there's increased hydrostatic pressure. Increased vascular permeability, again mediated by bradykinin, histamine, serotonin, and all those. And because of the increase in vascular permeability, there's transudation of fluid and protein and also leukocytes into that area. Yeah, stasis, like I mentioned, leukocyte migration. So this is how much time to give you an idea of how long this process usually should take. So there's an injury or an infection. So the fluid phase, meaning this increase in hydrostatic pressure, vasodilation, and increase in vascular permeability, it's immediate because the mediators are immediately released, and then neutrophils transmigrate into that area within the first day, and then eventually neutrophil will do its killing, and then also do its phagocytosis or whatnot. And then macrophages by day 2 to 3, it comes into that area and starts cleaning up the mess, and macrophage would manage. So if there's no persistent stimuli, the macrophage will go towards healing scar and formation, healing and scar formation. And this, obviously, like I mentioned before, healing and scar formation is mediated by TGF beta, FGF, and yeah, IL-10. Healing is IL-10, TGF beta more towards scar formation. So that can happen. Otherwise, if the inflammatory stimulus is still present, macrophage would then present the antigen to T helper cells and cause activation of adaptive immunity. So that can result in chronic inflammation, or the stimulant, the acute inflammation remains active and does neither resolve nor progress because there is no anti-inflammatory signals to stop that process. So IL-8 is something that, like, sustains this acute inflammation. So any questions till now? I know that was a bit long, and but it's a really important topic because acute inflammation is covered. You can see it in cardiovascular system, in most organ systems. You can see it. So any questions regarding this whole process of events? All right, so we will move on to leukocyte extravasation. So in between, like, I skipped over what was happening. It was like I just mentioned leukocyte extravasation, like the neutrophils reach that area, but how do they reach it? There is a whole process behind it, and it's well known. So you have to know this process, and the reason for this is if there is some defective if there are some mutations that affect this process, it leads to a disease, and that disease is kind of high yield for step one. So that means you need to know the whole process as well. So leukocyte extravasation. So this is the whole process. There are four main steps. There's margination and rolling of the neutrophils. Then they tightly bind to an area. Then there's diapedesis, meaning it's migration, transmigration through the leaky capillaries, how they migrate through between them. And then migration is going towards the chemokines according to the concentration gradient. So we'll look at each process in detail. Margination, it's a process by which leukocytes are distributed peripherally along the endothelial cells. So there are two ways, because usually when there's laminar flow of blood, all the contents of the blood vessel usually go in the middle of the blood because of the laminar flow. What happens is once there's dilation of the post capillary venules, you can you cause a decrease in the blood velocity, because the increased diameter, it's uh, basic blood flow. I mean, basic fluid mechanics. It basically works like this. So if you have a hose pipe and you let water come out of it, it will come out at a specific speed. But if you narrow the diameter, it comes out faster. If you increase the diameter, it comes out slower. So what happens is once there's dilation of postcapillary venules, the blood flow in that area slows down. So it allows neutrophils to, like, bounce around. Especially there's turbulent flow now. It can now hit on the endothelial cells, and maybe it'll bind into some receptors. But this process of the neutrophils going to the side of the cell is called margination. Another mechanism is called rouleau formation. So like Ashwin mentioned, in acute inflammation, there are some acute phase reactants, especially fibrinogen, which are increased in production. So once the liver increases the amount of fibrinogen in the blood, what happens is fibrinogen causes clumping of RBCs. So once there's clumping of RBCs, it pushes all these neutrophil cells to the side. Well, that's the mechanism that is mentioned behind margination of leukocytes. So two things. One is just because of the mechanics. Once there's dilation and there's turbulent flow, they hit the margins. Or if blood vessels are clumped together and they push the neutrophils to the margins. So now they reach the margin. Now they need to start. Now they start rolling along the margin. In this process, what happens is there are certain receptors on the endothelial cell, and there are certain molecular patterns on the neutrophils that allow them to bind slowly. They'll bind, but it's a weak binding. So the affinity for the receptor and the ligand is is very low, so there's weak binding, so it will slow it down but it won't completely stop it. So these adhesion molecules are called selectins. So you can remember this thinking about, like, neutrophils are trying to select the site to which they need to go. So they are trying to select the site through the help of these adhesion molecules called selectins. So the names of these on the endothelial cells, there's one thing called E-selectin and there's another one called P-selectin, both present on the surface of the endothelial cell. They are receptors, and then they are meant to bind specific ligands on the leukocytes. One of them is Sial-Lewis X, and the other one is L-selectin. So you might get confused. How do you remember P-selectin, E-selectin are on endothelial cells, but L-selectin is on leukocytes? So one way you can think about it is L-selectin, L for leukocytes. So L-selectin is on the leukocyte, Sial-Lewis X, because it's just different. And P and E-selectin, so the rest of the selectins should be present on the endothelial cells. So again, these molecules, Sial-Lewis X and L-selectin, when they transiently bind to the endothelial selectins, which is P and E-selectin, they allow the leukocyte to roll along the vascular wall, and this rolling slows them down. And so one important thing is, endothelial cells do not always express E-selectin and P-selectin, because we don't want normally our neutrophils to like get stuck to the side wall sides of the endothelial cells. So usually only as a response to inflammation, there's an upregulation of these proteins on the endothelial cell that is mediated by TNF alpha and IL-1. So this is an important thing to remember. So if there's TNF1 and IL-1, sorry, TNF alpha and IL-1, which are released from the primary site of inflammation, that will cause upregulation of E-selectin, and that eventually causes the neutrophils to come to that area specifically and roll in that area. Now they have rolled and slowed down. So they have rolled with low affinity integrin, then eventually it will choose an area where there's highest concentration of what is this, TNF and IL-1. There will be upregulation. There will be another molecule where it will bind, but this time it will bind tightly. So now the neutrophil will get stuck to the endothelial cell. So leukocyte adhesion, that is the next step after rolling. So it slowly rolls across and eventually firmly binds to one of the one of the receptors on the endothelial cell. This is called ICAM and VCAM. Again, both of them are upregulated by TNF and IL-1. So you can think about it in a logical way. If there's inflammation over here, so these microbes, then these macrophages are releasing TNF and IL-1. They are upregulating only in this specific area, the E-selectin, P-selectin, ICAM and VCAM. These will mediate the rolling and then eventually the tight binding. And tight binding, so the molecules you have to keep in mind, endothelial cells, it's ICAM and VCAM. On the neutrophils or the lymphocytes, on neutrophils it's specifically LFA1, and on lymphocytes and monocytes it's called beta-1 integrin. So the names of this is kind of important to remember, because there is a disease in which there are kids who are born without this beta-2 integrin. So there is no molecule on the neutrophil to bind to the ICAM. So that means neutrophil cannot reach or tightly bind to that area and go through the whole process and reach the site of inflammation. So these people cannot produce. So a characteristic feature is they'll have if they have inflammation, they won't have pus formation, because pus is basically neutrophils, dead bacteria and all that war happening, but that war won't even happen if neutrophils don't reach that area. So these kids, they'll have a bacterial infection without pus. That's one thing to keep in mind, and that's because of a mutation in the beta-2 integrin, CD18. So the CD18s, they bind to ICAM, cause tight binding. So now tight binding has happened. Yeah, this is just a uh, illustration of, if there is a deficiency in any of the molecules involved in one of the process, then there is a disease, clinical disease. You don't have to know all of them. The one thing that commonly pops up is this one, the leukocyte adhesion deficiency of type 1. Type 1 is basically beta 2 integrin not being formed, so CD18 mutation. Just keep that in mind. We'll go over that during primary immunodeficiency syndromes as well. So once the adhesion has happened, next we need transmigration. So transmigration or diapedesis is the movement of the leukocyte, which is neutrophil in this case, across in between the cells. So already vascular permeability has been established. So this leukocyte will start transmigrating. Again, we need to know the mechanism. So this is also again by binding of different types of receptors. So we have these receptors are called PCAM. So how you can remember this is this process is called diapedesis. This is in first aid. So the P for PCAM, this maybe it's helpful, an endothelial cell adhesion molecule on neutrophils, endothelial cells, and platelets. So this transmigration process is present on all neutrophils and endothelial cells, and as you saw before, there were different receptors on endothelial cells and the neutrophils for these cases, but for transmigration there's PCAM on the endothelial cell and there's PCAM on the neutrophil. So both have PCAM, so not much to remember. They bind to each other and cause the transmigration. So again, a summary: resting state leukocyte usually in the middle. Then because of increased turbulence and there's margination because of increased turbulence that will cause the leukocyte to start rolling along the endothelial cell. It'll bind to the p-selectin and e-selectin, and this will slow it down, and eventually it will go into the tight adhesion through the LFA1, which is LFA1 and ICAM1, which is the beta 2 integrin. It's a tight binding, so now it found its spot, and then the vessel permeability is already there, so it will do transendothelial migration through binding through PCAM. So as you can see, there's a PCAM on this, there's a PCAM on this, so they just PCAMs just help it move along. Yeah, migration. Then eventually after it has traversed through the like across the blood vessel, it still needs to get to the site of the inflammation. So that is basically like how a dog would sniff out cocaine or something like that. It basically goes towards the concentration gradient. Yeah, so that's how leukocytes they go towards these chemotactic factors. So like leukotriene B4, IL-8, complement C5a, or some kind of bacterial products are also chemotactic, which specifically is N-formal peptide. But yeah, these cause chemotaxis. Neutrophil goes to that area and then starts doing its job. Again, just another picture to help you remember the whole process. So PCAMs helps in transmigration. ICAM is on the endothelial cell, binds to LFA. LFA is beta 2 integrin, and rolling is done by E-selectin, P-selectin on the endothelial cell, and L-selectin and Sial-Lewis X on the neutrophil. That's about it. Yeah, this is that leukocyte adhesion deficiency I was talking about. So these kids, they'll have infection without pus formation, and also they have this specific finding which is very characteristic called delayed umbilical cord separation. So what that means is usually when we are born, we clamp our umbilical cord, and usually there's a stump which just dies off after after 2 or 3 days, maybe maximum a week or so. The reason it dies off is because once you clamp that area, it's not getting a blood supply, and it will undergo necrosis, and then there's an once there's necrosis, it will trigger acute inflammation. Neutrophils come to that area, they degrade that area, macrophages clean up that area, the stump eventually falls off. But in leukocyte adhesion deficiency, their neutrophils cannot reach that area, so the umbilical cord cannot be separated. So eventually what have in these people, there's delayed umbilical cord separation, usually greater than 21 days, and the reason how it eventually falls off is either it gets infected and we have to remove it, or it just becomes so necrotic that it just dies off. Yeah, then once neutrophil reaches that area, it goes through something called neutrophils, they will phagocytosis phagocyte yeah, they will eat up that bacteria. It's called phagocytosis, and this is also again mediated by receptors. So receptors on the Neutrophils will recognize ligands on the bacterium. They will bind and then eventually endocytose, meaning it endocytoses the bacteria and it forms something called a phagosome. And then phagosome fuses with the lysosome, because lysosome is the one that contains all these hydrolytic enzymes. Uh, so once that fusion happens, so these hydrolytic enzymes degrade the bacteria through, like as we mentioned before in the previous session, the creation of free radical oxygen and respiratory burst that Ashwin talked about using NADPH oxidase, superoxide dismutase, and finally the production of hypochlorite, uh, which is toxic to the bacteria, causes free radical damage. Bacteria dies, broken up, cellular debris is released through exocytosis, and the cellular debris is eventually cleaned up by macrophage that comes in. So again, another clinical correlation. So I mentioned something here that this lysosome, which contains the hydrolytic enzyme, has to fuse with the phagosome, which is what has been endocytosed with the bacterium. So if there's no fusion, usually mediated by microtubules, which are like frameworks so that these can move along them and bind together. If there's some kind of problem with phagolysosome fusion, then you can obviously not kill the bacteria that you have over here. So they will just live in the phagolysosome. No, they won't even form a phagolysosome. They'll just live in the phagosome, and you will have recurrent infections, as you can see. This syndrome is called Chediak-Higashi syndrome, and one of the things that you see, one of the clinical manifestations is recurrent bacterial infections, because you lose your bactericidal effect. But these people also have like other symptoms like albinism and neuropathy, peripheral neuropathies, because the defect is actually in a microtubule, and microtubules are involved in a lot of other things as well. This is just a recap of what we saw last class. This is how the respiratory burst happens. Just a quick recap. So first we have oxygen. NADPH oxidase degrades it, creates a superoxide anion, and then superoxide dismutase converts it to peroxide. Myeloperoxidase then converts it to hypochlorite. I think it's hypochlorite. And hypochlorite, because it is extremely charged and it's extremely reactive, it causes free radical damage to the bacteria and done. And usually we have ways to, because these are also toxic to our cells. Our cells have methods to prevent damage to our own self using the G6PD pathway, which Ashwin also talked about last class. But this G6PD pathway in some people can be deficient, and therefore this free radical damage can accumulate in these patients and eventually end up destroying the red blood cells, which where they have anemia, hemolysis, and all those stuff. This is a patient with inflammasome, not inflammasome, sorry, uh, what do you call the disease that we saw before? Yeah, chronic granulomatous disease, uh, because of NADPH oxidase deficiency. So if you are deficient in the first part, you cannot convert the oxygen into superoxide. So what happens is you cannot produce all these toxic material for the bacteria, and so the bacteria will be able to survive. But in that's why these people have recurrent skin infections or recurrent bacterial infections. Yeah, so now that is all about acute inflammation and some clinical correlations. Do you guys have any questions in this topic before we move on to chronic? All right, so Ashwin, you can continue with chronic inflammation.
Yeah, chronic is a small topic, so then we can take a break after we are done with this, maybe. So we have talked about a lot of stuff, and most of this is just an extension of that. So hopefully this shouldn't take long, and it should be easy to understand as well. Right. So there was a slide in which Abhi talked about the outcomes of acute inflammation. Either we successfully resolve it and we move on with ourselves, or we do not resolve it and there's chronic inflammation, or there's persistent acute inflammation, or there's scarring and other procedures, right? So chronic inflammation is one of those situations in which acute inflammation happens, but it's not sufficient. It doesn't take care of the pathogen, so we have chronic inflammation. Just like the causes of acute inflammation, any pathogen or autoimmune diseases can cause chronic inflammation. But the only difference in this situation is the amount of time that we've spent with the pathogen. As most of us might know, that TB is a very, very chronic disorder, right? More than 1/3 of the population in the world has TB, and one of three people, that means one of three people have it. But the reason we don't express symptoms about all that is because our immune system has found a way to for us to live with TB, right? So it has cornered TB into a small something called a granuloma, which Abhi will talk about. It has cornered TB from all sides and made it very concise, but it's still part of our body, and hence there will be chronic inflammation if we are affected with TB. There are autoimmune diseases where cells from our body attack our cells. So in this scenario as well, because the irritant is from our body itself, we'll never get rid of it, right? Most common examples are SLE and rheumatoid arthritis. So SLE, systemic lupus erythematosus. We'll touch about it later when we talk about immunology and other rheumatic diseases. So in both of these situations, it's our immune system falsely recognizing a normal cell as a pathologic cell and attacking it. So in both these situations, since the instigator itself is in our body, it's a chronic procedure and it results in chronic inflammation. And obviously, smoke is one of the most common irritants that we see in our environment. And it's not an acute reactant. It happens over a long period of time. Even smokers who are addicted, they are exposed to smoke for a really long period of time. So it results in chronic inflammation. And hence the term COPD, right? Chronic obstructive pulmonary disease, because it's a chronic process. It takes a long time to happen. And once that happens, there's obstruction and there's pulmonary disease. So smoking causes COPD. A lot of the common diseases that we come across, cardiovascular diseases, even diabetes, in obviously type 1 diabetes is because of an autoimmune attack and there would be chronic inflammation, but even type 2 diabetes that develops because of our genetic predisposition and our diet is also an example of chronic inflammation, because our adipose tissue secretes a lot of cytokines and chemical mediators that, like all the factors that we have mentioned before, all those factors are activated because of adipose tissue and they can cause chronic inflammation. So all you got to remember for chronic inflammation is that everything that happens in acute inflammation continues to happen: vasodilation, migration of immune cells. But the most important players in this game, the most important, like you say, generals in this war, is macrophages and lymphocytes. We talked about how neutrophils are what respond first. They come first to the crime scene. They're the, let's say, the constables. They come there, they do the survey, they do what they got to do for a couple of days, and then they don't leave as such, but then their role, the importance of their role decreases, and macrophages and lymphocytes take over. You have to remember that macrophages and lymphocytes are the ones that are responsible for chronic inflammation. And also, what are the outcomes of chronic inflammation? So acute can lead to chronic inflammation. Once that happens, there are one of three things, a few more important than the other. We have already discussed amyloidosis, how serum amyloid A can be secreted and that can cause amyloidosis. There's one more outcome is scarring. So that happens when a lot of tissue doesn't have regenerative capacity, or they have reached the limit of their regeneration, because of which they cannot regenerate. And that's when connective tissue will replace uh, the actual original tissue, right? And that's when scarring takes place. So we can have scarring, we can have amyloidosis, but most importantly, we can also have cancer. I've given three examples here. And in any organ of your body, if there is a chronic inflammatory state, it is a nidus for cancer. So because think about it, cancer is basically an accumulation of mutations. When you have inflammation, you have pathways that lead to NFK kappa, nuclear factor kappa activation, and when that happens, there's more production of inflammatory cytokines. But that happens at the level of transcription, right? So the more you undergo transcription, and the more the amount of mitosis and cell reproduction, more the chance of cancer. So anytime chronic inflammation takes place, always keep in mind that there is a potential for cancer. Three clinical correlations. One is hepatitis infection, hepatitis B, or hepatitis C. Both of them, hepatitis. Hepatitis means inflammation of the liver. Anytime you add itis to the end of the word, it means inflammation. Hepa obviously means liver, so hepatitis is inflammation of the liver. And since hepatitis C is usually a chronic inflammation, as in it dwells in the liver for a really long time, it can lead to hepatocellular carcinoma, HCC. It is one of the most common causes of liver cancer, which is HCC, is hepatitis C infection. The other one, I've already mentioned one common cause of ulcers, which is NSAID use, and the other common cause of ulcers is an infection because of a bacteria called H. pylori. It's Helicobacter pylori. It is the person who figured out that this bacteria is the one that causes ulcers was also given a Nobel Prize, I guess. So, can you guys hear me well?
Yes.
Yeah. Okay. There's just annoying sound in the background. But yeah, so H. pylori is another infection that can cause ulcers in the gastric or the duodenal area. And when that happens, usually when we get ulcers and we treat it with a PPI, we feel better because there's less acid in our body, but we do not get rid of the instigating factor, which is a H. pylori infection. So if you treat acidity with a gastric ulcer or a duodenal ulcer with just a PPI, if it is caused by NSAIDs, well and good, you might feel better when you stop using NSAIDs and you start using PPIs. But if the cause of the ulcer is H. pylori, we have to treat the infection in itself. So that's when we give antibiotics like ampicillin. If we don't do that, the H. pylori can continue to cause chronic inflammation, and that can lead to gastric adenocarcinoma. Because it's glandular tissue, so we will get to the nomenclature of cancer. It's called an adenocarcinoma because it's a glandular tissue and it's a gland that produces secretions. And the third example is that of a squamous cell carcinoma. Chronic wounds, like imagine any ulcer on your leg, a diabetic skin ulcer, or an ulcer because of varicose veins in the legs, where there are faulty veins and blood is static, because of which there can be bacterial growth and all that. So when you have an ulcer and you keep trying to treat it, but because of the diabetes or because of the location, the gravity dependent location that is your legs, you do not have good blood flow, or you do not have good, like initially in the beginning of the lecture, Malika had mentioned about hypoxemia. So diabetes messes up your vessels, and you can have hypoxemia and vasoconstriction and all that kind of jazz. And because of which you cannot heal properly. So you have chronic non-healing wounds. That is also a nidus for cancer. Specifically speaking, squamous cell cancer of your skin. It is a common USMLE question where they mention a person who probably had a wound for a really long time, and he comes back because it's not healing, although you gave him ointments. So one of the things that you should do is a biopsy, because there's a possibility of cancer. This is just a slide again. In this slide, so Abhi had showed you a slide of acute inflammation. One of the things that you had to look out for in that histology is that a lot of the cells had what you would call a hypersegmented nuclei, because the cells were neutrophils, and in neutrophils, the nuclei have a lot of segments. So when you want to figure out what cells are you looking at, one of the ways you can do that is by differentiating the nuclei, and here you can see that. Right. So one of the things that you can do is look at the nuclei. So the initial slide that Abhi showed had cells with a lot of, which looked like a lot of nuclei, but in reality is just one hypersegmented nuclei. In this slide that I'm showing right now, you can see it's one big blotch of nuclei. and that is characteristic for macrophages and T lymphocytes, which are the main mediators of chronic inflammation. So this is the game. Oh, sorry. Yeah. So initially we have monocytes that are not completely differentiated, and depending on the chemical messages and depending on the solution that it is in, and depending on the gradient, they differentiate separately. So there are one of two things that can happen in the initial phase of chronic inflammation when it is still in the inflammatory process. There's a certain type of macrophage called M1 macrophages, and that is pro-inflammatory. It increases inflammation. It recruits much more immune cells using chemical mediators, which Abhi had already mentioned. Some of which Abhi has already mentioned in the form of interleukin-1 and TNF alpha. So it recruits more immune cells and increases the amount of inflammation. But on the other hand, we have something called the M2 macrophage, which comes later on the second half, where it has anti-inflammatory effects, and it causes fibrosis or decrease in inflammation and kind of like wound repair. So you have to remember, one of the two things that you have to remember is that initially when the monocyte is derived from when the macrophage is derived from the monocyte and it is not differentiated, there are one of two ways it can go, and depending on the chemical message it receives, it will go either one of those ways. So the cell that gives it the chemical message, one of the cells that gives it the chemical message is the T lymphocytes, but in specific the helper T lymphocytes. It's called CD4 positive. CD4 just means cluster of differentiation number 4. So it's just a marker that we use on cells. There's a nomenclature for T lymphocytes, and we have divided them into CD4 and CD8 based on the markers that is there on the cell surface, and obviously the function is also different. So in this case, there is a CD4 T lymphocyte, as in there's a marker which is there's a CD4 marker on the surface of the lymphocyte, which secretes a chemical mediator called interferon that causes the macrophage to be differentiated into an M1 macrophage. This is really important for you to remember, that the mediator that is secreted by the T helper cells in this case is interferon gamma. Okay. And also another way it can be activated is by LPS, which is lipopolysaccharide, which, as I mentioned in the initial slide, is it's a sugar chain present in the bacterial cell wall. And even that can help macrophages differentiate, because think about it. Obviously, if the pathogen is still there, you don't want to heal right now, right? You still want to fight before you heal. So the next step would obviously be to convert it to an M1 macrophage, and from there on, think about what we can do. But in the other scenario where there is where you want the macrophages to initiate healing, there are other cytokines called interleukin 4 and interleukin 10. Again, it's very important that you remember these interleukins, because it's not only this process. Even when I talk about wound healing or when I talk about anti-inflammatory processes in the future, you have to remember that it is interleukin 4 and 10, because there'll be a certain amount of cells, certain type of cells that secrete these interleukins. So you need to realize anytime those cells show up, it means that their function is anti-inflammatory, because they release interleukin 4 and interleukin 10. So APC means an antigen presenting cell. They're usually cells like dendritic cells that are part of the innate immune system. What they do is they take in the pathogen, they chop it up, they take one part of the pathogen that is presentable, and then they show it on their surface. And then a T cell comes along, takes a look at the pathogen, tries to bind with it using its receptor, and then depending on what it decides, it'll either do one or two things, right? It can make the macrophage, it can secrete interferon gamma, and it can make the macrophage into an M1 type, which will further cause inflammation, or it can go the other way around and it can secrete interleukin 4 and interleukin 10, which helps which is anti-inflammatory. It's all you got to know, and you have to know that TH1 is the subset of the T helper cells, subset of the CD4 T cells that codes for interferon gamma, and TH2 is the subset of T cells that codes for interleukin 4 and interleukin 10. All the other interleukins, we'll touch on them when we do immunology, which is not far away. Yeah, so we've talked all about how we damage our cells, how we fight them, and now it's to talk about how we recover from all the injuries. So wound healing, this is basically something that you have to apply to root memory. There's no way to apply logic to it. So basically, growth factors act in an autocrine or a. Do I have it in the next slide? Sorry. Okay, I'll just tell it. So basically, we have a lot of growth factors, which the name itself is very self-explanatory. Growth factors, as in they stimulate growth, and there are different types of it, like fibroblast growth factor or tissue growth factor beta or vessel endothelial growth factor V, like vessel endothelial growth factor or platelet derived growth factor. All of these are growth factors that stimulate growth, but they stimulate different components of growth. Most of the names again are self-explanatory, like in the case of, let's say, VEGF, right? Vessel endothelial growth factor. It is kind of obvious that endothelial growth factor, the cell that lines the blood vessel, which is the endothelium, will obviously be stimulated by VEGF, because in the name itself, it says VEGF, vessel endothelial growth factor. So VEGF will stimulate angiogenesis. The only ones that require special mention because the etiology of the name itself is not related to the function is FGF. It says fibroblast. It expands to fibroblast growth factor, but its function again is angiogenesis. So these are anomalies, and USMLE loves anomalies, right? So you have to remember that angiogenesis, which means making new blood vessels, is stimulated by FGF. And everything else you have to commit to memory. One I've already mentioned is VEGF for angiogenesis. Transforming growth factor beta is really important. You need to realize that, again, this is anti-inflammatory. First thing that you have to realize, it says anti-inflammatory, so it decreases inflammation. And second thing, it promotes tissue repair by increasing the blood vessels and also increasing the amount of fibroblast you recruit to the crime scene. PDGF is another anomaly because it is platelet-derived growth factor. Although it does stimulate the platelets and helps in vascular remodeling, it also does another very important function called smooth muscle cell migration. So whenever a wound happens and there is a cut in your skin, right, there has to be a way by which you contract those edges, pull those edges together, and help decrease the gap between the two sides of the wound. And that is done by myofibroblasts. And for that, you need smooth muscle cell migration, and that is done by platelet-derived growth factor. Another one is metalloproteineases. We mentioned on it before when he talked about how neutrophils act, how they migrate from the vessel, and they basically dig their way through the extracellular matrix. So they have to destroy tissue on their way, right? And the way they do that is by secreting enzymes called proteineases. Most of our body is made up of amino acids and proteins. Proteineases, as in stuff that degrade protein. So metalloproteins degrade protein and they dig their way through. EGF it also has a really good clinical correlation, so you have to remember it. It's that EGF also stimulates cell growth, and the mechanism by which it does that. So I had mentioned that there's PAMs, or there are receptors that attach to growth factors, and from then on it's called downstream signaling, where there are stuff that happens in the cytoplasm and later on ends up stimulating the nucleus to code for something new. So the way EGF works is a method called tyrosine kinase. Initially, I'd mentioned three methods: NF-kappa beta, JAK stat, and MAP kinase. So tyrosine kinase is one of those methods by which you can reach the nucleus. It's not important to know exactly how it happens as of now. We will touch on it later, but you have to remember that that is how it functions. So there are 4 steps in wound healing. It's very easy to understand. So the first step is obviously there's vasoconstriction and release of thromboxane, and every time you have a wound, there's collagen that is exposed. Previously, I'd mentioned about how there are coagulation cascades. It's called intrinsic and extrinsic cascades that help with secondary plug formation. Initially, you form plugs with just platelets, and then you form stronger plugs with the help of fibrin and everything. So when you form a primary plug with platelets, you need fibrin and platelets. Fibrin acts like a glue. Platelets come together and they form a plug. So the first thing you obviously got to do when you're injured is to patch it up. So you patch it up with platelets. First step would be, like it's mentioned here, every time there's a rupture of a cell membrane or secretion of the platelet granules, you secrete thromboxane, which causes vasoconstriction, but that's very transient. After that, you have vasodilation, and all these inflammatory cells like macrophages, lymphocytes, and neutrophils, they secrete histamines, prostaglandins, and leukotrienes. They all have their functions, which you've mentioned before. It causes vasodilation and all the cardinal signs of inflammation, along with which it causes the platelets to aggregate and also start the first step of wound healing, which is exudative phase, which is when the platelets aggregate. It's the most important component of this phase of healing. The second phase, day 1 to day 3. So just like acute inflammation, initially you have neutrophils at the site, and they are the main players. Neutrophils come and they digest all the dead tissue, or they fight the pathogens, and now they create a lot of debris. And after the neutrophils come in initially, then it's followed up by macrophages and lymphocytes. They're part of the adaptive immunity. They come when before things get too ugly, they reach there and they try to launch a better attack than innate immunity. And they also end up causing a lot of debris. But macrophages, not only do they activate a lot of immune cells, like we mentioned, but there are also M2 macrophages, right, that are anti-inflammatory, and they trigger angiogenesis, and they recruit a lot of fibroblasts. So that also goes on in this phase. So initially, there are a lot of immune cells that come in and create debris, and there are also immune cells that start the process of tissue repair by recruiting fibroblasts, and also the keratinocytes that make up your epithelium. They start to regrow. So you have to remember the main players. Day 1, it was neutrophils. Day 1 to the rest of like day 2 and day 3, it was macrophages mainly. And now day 3 to day 7, we are still in the first week of wound healing. So suppose you get a scab, you know that is the first week that is crucial, and it's still bloody in the first week, and there's granulation. So a couple of days after you get the injury is when you see to the top bottom right corner, you have an image of the injury that you. If suppose you had an injury, this is how it would look a couple of days later, right? There's granulation tissue, soft, very boggy tissue where it easily bleeds because there are a lot of fragile blood vessels in it, and the sides, the two corners of the wound have not come together yet, and there's tissue popping out of it, and it's really blood red because of the blood vessels and the supply. So obviously, when you want to grow tissue back, you need a lot of blood, and you need a lot of nutrients, you need a lot of oxygen. So there are a lot of there's angiogenesis because of FGF, like I mentioned before. FGF and VEGF cause angiogenesis, and there are a lot of new blood vessels forming. On top of that, there is a platelet-derived growth factor that causes smooth muscle cell migration, and they're trying to get the two edges of the wound together. And there are fibroblasts trying to repair the damage in the dermis. And there are epithelial cells that are trying to form new keratinocytes. They're trying to differentiate from stem cells into more specific cells in the form of keratinocytes, and they're trying to replace the tissue on the top. Now, the most important thing that you have to remember is, so initially when you're trying to lay down collagen in the epidermis, the type of collagen that is laid down is collagen type 3. Mentioning it again, the type of collagen that is laid down during granulation is collagen type 3. There are 4 main types of collagen, and collagen type 3 is lesser. The tensile strength, the strength of the collagen type 3 is lesser than that of what is normally seen, which is collagen type 1. So it is really important to know that when you first lay down collagen, you lay down collagen type 3, which is then replaced by collagen type 1 in the next phase of wound healing, which is maturation. So the main process in this is clearance of we have already established as collagen type 3 is there at the wound site now. Now again, you have to secrete something called collagenases, which is a type of metalloproteinase, digests collagen and degrades collagen type 3, and collagen type 1 is collagen type 1 is produced at that spot. This collagen type 1 has a much better strength than collagen type 3, and by about 60 days after the injury, you would have reached the most amount of strength that you would like suppose you have an injury and 3 months later, let's say your 80% of your initial strength is retained. That is as much as it would go. Even if you give it more time to heal, there are not many changes that would take place. So you have to remember that the golden period is around 60 days, but they say 3 months, even 3 months. Once you've reached that limit, the strength of the tissue won't change majorly after that. So the takeaway points from the whole wound healing procedure is that first you have a platelet plug formation, in which there's initial vasoconstriction and then vasodilation. Then all the neutrophils come in. There's an inflammatory. All the immune cells come in. There's an inflammatory phase. They fight the pathogen, and there's a lot of debris formation. And now they secrete a lot of factors that is helpful for tissue repair, where there are FGF, PDGF, and VEGF. All of that come in, and growth is stimulated. And finally, there's maturation. Whatever you lay down as granulation tissue is replaced with good permanent tissue in the form of type 1 collagen, and you get almost all of your strength back in the first 3 months. That's your takeaway from that. And again, like in any other process, this process can also make mistakes. And so one of the two things that can happen is in scar formation is either hypertrophic scar or a keloid, the two most common forms of aberration. In hypertrophic scar formation, you have the normal type 3 collagen, but it doesn't stay confined to the wound. So you have a flat wound and there's a gap between the two edges. Instead of just filling the gap, it overgrows it by a little. It's mainly of cosmetic concern, but other than that, there's no worry that it can happen. So there's no worry that the next time you get a wound, this phenomenon has to happen again. So there's no recurrence rate. Neither is any other, like there's no other pathologic concern other than the cosmetic effect of it, of course. On the other hand, keloid can be much more concerning. So in hypertrophic scar, the major type of collagen was type 3, but in keloid, the collagen there's both type 1 and type 3 collagen, and because of which it's much more disorganized and it grows exponentially much more than hypertrophic scar. In hypertrophic scar, although it's not flat, it has increased its borders only by a little, but in case of keloid, it just grows all over. I mean, it extends over his borders by a margin a lot more than the hypertrophic scar. You can see the photo and it's very self-explanatory. Like, in case of a hypertrophic scar, you see that there's only a small bump, but in case of a keloid, there's extremely excess tissue growth. And the fact that it's type 1 and type 3 collagen will make it really sturdy tissue. And also, if you get a keloid in one part of your body, there's a high chance that when you get injured again and there's tissue repair happening in some other part of your body, the whole process of a keloid formation can happen there as well. And lastly, there's a predisposition that, as in people of darker skin are more likely to, there's some part of their genetic code makes them more susceptible to keloid formation. That is all it means. So there's an increased incidence, as in there are a lot more cases of keloid formation in people with darker skin. These two are just things that you should remember, and when tissue repair happens aberrantly, when there's something wrong with the tissue repair. Yeah. Hope you guys are not too tired. We can take a break, or we can do a question maybe. Up to you guys.
Questions?
Yeah, so we can try and do one question then. How about you guys go for a break, and the first thing once you come back is we'll do a question and then we'll move on. Is that okay?
Yeah, okay.
Cool. All right, guys. Let's do a couple of questions. Sorry for the short breaks. It's just a really big topic. Right. So go ahead. I'll give you a minute to go through this question and then we can discuss. You can write the answers in the chat box. You're all here, right? Guys? Oh, cool. Saina, do you want more time? Let's discuss this. So, 32-year-old chef accidentally slices into the while hurriedly trimming ribeye steaks with a knife. The laceration extends through the skin into the subcutaneous pulp. Which of the following sequences is most likely to occur in the subsequent wound healing processes? All right. So we went through the steps of wound healing. What was the first? Anybody? Like, just tell it out loud. First step.
Platelets aggregation,
Right. So what was the thing that helped the platelet aggregate?
the
Right.
fibrate formation.
Exactly. So option E and option F are the ones that have suggested that fibrin formation is the first thing that takes place. So it should have been one of them. What was the second step in wound formation, wound healing? Somebody?
The neutrophil infiltration and
Right. So for angiogenesis to take place, we need these cells to come in and secrete factors and cytokines and all that. So before the factors come in, before the cells come in, we cannot have angiogenesis. So the second step was cellular infiltration. And then after these cells come in, do the job of cleaning, and now we need more supply to regrow the tissues. That's when we do angiogenesis. Because think about it. Um, we cannot start repairing before we kill the pathogen and fight the disease, so we cannot have angiogenesis before cellular infiltration. And likely for the platelets to form a clot, we do not need new cells to come in. We don't need neutrophils or macrophages to secrete anything for the platelets to form a clot. All it needs is that there should be exposed collagen, And as soon as platelets see that, they start going to work and they form the clot. So first you form a clot, then cells come in, and then angiogenesis takes place. So the correct answer is F. Good, good stuff, Kushal. So yeah. Okay, so this is the U world explanation for what goes on. It's a nice pictorial representation. Bacteria and cells. So bacteria causes cell damage, and there's platelets, the first cell to arrive at the scene, which is like it's all over your blood vessels and just aggregates at the point of injury, and it starts forming a clot. And after that happens, you have cells that come in like neutrophils and macrophages that predominate. The Those two cells are predominant in the site for up to 5 days, and when as soon as that happens, there's vasodilation, there's chemotaxis of more immune cells, and also there are a lot of growth factors being secreted. And then slowly the macrophages change color. They go from M1 to M2, and they start secreting more growth factors rather than recruiting more immune cells. And once they start doing that, there's more TGF, there's more FGF and VEGF. That's when we start making new blood vessels, new epithelial cells, new fibroblasts, and type 3 collagen. And finally, we just replace a type 3 with type 1, which is stronger, and we are done. So, this is their explanation. So, there was a wound instigated by a knife, and all they wanted to know was how you heal. It didn't matter what caused the injury. Uh, and then every time there's an injury, healing process occurs in four steps: hemostasis, inflammation, proliferation, and maturation. Hemostasis was the first step, and the most important part of that is small vessel constriction and platelet aggregation, which is put, and the platelets are kept in place together with a fibrin clot. And after that is when inflammation takes place. During this phase, you have a lot of inflammatory cells that secrete chemical mediators that help fight the disease, as well as recruit more cells like neutrophils to digest the bacteria and carry away the dead soldiers. And then the final stage is proliferation, where you secrete growth factors and everything you lost is brought back to life. And then finally, you just reinforce your type 3 collagen with type 1 collagen. So you guys should remember these steps as well. Yeah. So quickly, this question as well. This shouldn't take a lot of time either. Yeah, it was a little tricky. UWorld is usually like they try to trick us. Just you have to be very careful in what is the what they want from you, and what they mean by what they say. So read carefully, and you'll get it right. Try this one again. 1 minute, and we'll see. Guys, can you start guessing? All right. Any other guesses? Yeah, I think all of you responded. So let's go through the question. A 34-year-old woman comes to the office due to vague abdominal pain for the past several months. She has no significant past medical history. The patient does not use tobacco or alcohol. Her temperature is 36.7, which is normal. On physical examination, she has right upper quadrant fullness and is present. So right upper quadrant is the abdomen, and if you divide it into 4 quadrants, this is the right upper quadrant. That's where the liver is. And in the next question, in the next part of the question, they go on to say that abdominal imaging reveals a dense liver mass, and angiography shows a well demarcated, highly vascular tumor surrounded by normal liver parenchyma. So, angiography is when you put dye into your vessels and you put in an X ray image. And when they did that, they saw that around a certain tumor as a mass, there's a lot of vascularization. As in, you put a dye into it, and you're seeing a contrast image, and now there's a lot of contrast around that tissue. That means that there's a lot of blood circulating around it, which means there's a lot of blood vessels. Which of the following substances most likely contributed to the blood vessel development in this patient's tissue? So there was a slide that I had shown that there were different growth factors, and I had mentioned that there were a couple of them that was an anomaly, as in their name didn't exactly suggest what they did. So we had growth factors that were responsible for angiogenesis, which is what they're asking. Blood vessel development means angiogenesis. Can anybody recall what were the growth factors responsible for angiogenesis? One of them was platelet-derived growth factor, right? And I had mentioned that vessel. Sorry, I made a mistake. So one of them was VEGF, vascular endothelial growth factor, as in endothelium, the cells that make up the blood vessel. Growth factors for them will obviously lead to new blood vessels. The other one I said was an anomaly, as in the name doesn't suggest what it did. Can anybody recall what that was?
Fibroblast growth factor.
Exactly. Yeah. So we had mentioned once. Maybe I should stop presenting and present the other one. Give me a minute. Yeah. Right. Can you see my screen? There's VEGF that stimulates angiogenesis, and with that, there's FGF highlighted in yellow, and it says it stimulates angiogenesis. So the question was, what was responsible for the high vascularization of that tumor? As in, what was responsible for the increased amount of blood vessels around that tumor? So since there was no VEGF or TGF beta in the options, the correct answer was FGF, which was option number 2, if I'm not wrong. I'll just start casting that again. So there's these small details that, like suppose me or Abhi mention something twice or say that it's an anomaly, you guys have to make sure that you remember that, because the fact that it's an anomaly means that, chances of it being asked is extremely high. So you always remember anomalies. So the correct answer was B. So they said it's a highly vascularized tumor, as in there's a lot of blood vessels around it. So most likely it's a hemangioma. Abhi will talk about the nomenclature of tumors after this question, so you'll understand what a hemangioma is. But when that happens, there's a lot of blood vessels. What you had to know to figure out the answer was that what are the growth factors responsible for making new blood vessels. One was VEGF. We have mentioned that, and the other one was FGF, and it produces. So it's written that it's produced in a wide range of cells. It helps with endothelial cell proliferation, migration, and differentiation, as a group, FGF not only contributes to angiogenesis but also to embryogenic development, hematopoiesis, and wound repair. The laminin basement make positive. So that was the relevant information for you to get the answer to that question. All the other answers and all the other options in this question, EEGF, do not confuse it with VEGF, right? Epidermal growth factor is different from vascular endothelial growth factor. So VEGF is different from EGF, and EGF will play an important role, and we'll talk about it when we talk about cancer right now. It helps in this growth of epidermal cells, but not angiogenesis in specific. It doesn't have any role to do with blood vessel development as such. Other things, insulin-like growth factor. It's usually, so we have something called growth hormone in our body, which is responsible, like most of you might have heard of it, increase in height and increased metabolism and all that. And the way it does that is by increasing the production of insulin-like growth factor, and all the actions that growth hormones does is via the secretion of IGF-1. And the last two options, some of you had chosen a few of them. So we had also mentioned that interleukin-1 is part of the inflammatory response, and it initially recruits immune cells, but in specific, it doesn't do anything for angiogenesis. It recruits immune cells that in turn something for vasculogenesis, but in specific, it doesn't do anything for vasculogenesis. So you have to remember that although interleukin-1 is pro-inflammatory, doesn't have anything to do with angiogenesis. Similarly, interferon gamma is what I had mentioned for chronic inflammation. I told you that interferon gamma is secreted by T cells, CD4 T cells, TH1 subtype, and it in turn it activates macrophages, converts them into M1, which causes more inflammation. So both interleukin-1 and interferon gamma are the wrong answers. They are part of inflammation, but they are not directly involved in angiogenesis. Yeah, that is all in terms of questions for now. We'll do neoplasia, and then we'll do a few more questions on that. Right. Yeah, I think Abhi will take over now. So guys, be careful, read the question thoroughly, and remember the extremely important details first, and then go ahead from there.
Yeah.
It's all clear, right? Did you guys understand why the correct answers were correct?
Yes.
One second. Yeah, so now we'll just quickly look at granulomatous inflammation. So granulomatous inflammation is a type of subtype of chronic inflammation. So when you have some kind of chronic inflammation, it can proceed in a way that ends up forming granulomas. So that would be called a granulomatous inflammation. And granuloma is basically a round structure. It's like a granule, and it's filled with it's attempt by our body to wall off a foreign substance. So suppose you have berilliosis, silicosis, like if you're exposed to beryllium or silicon, or if you have an infection such as TB or a fungal infection, these things our body cannot sometimes deal with them. So what they do is they'll just wall them off, like in sort of a cavity, surrounded by inflammatory cells. Especially we'll look at which cells typically, but this granuloma will be formed, and the infection and all the war zone will be blocked by certain inflammatory cells. So and this, because the actual pathogen is still present in the middle of the granuloma, what happens is there's persistent inflammation because there's continuous fighting going on, cytokines released, and this inflammation causes more granulomas to form all around the organ. And then because inside in the middle of the granuloma usually there's like necrotic material, dead cells. So if it happens in a lot of places in your organ, then you will end up with organ damage. And then eventually, once there's enough damage, fibrosis will happen, just like in wound healing, because of TGF beta. And yeah, the organ will lose its function. So this is how a granuloma would look like. Things to notice: So this is the war zone basically that we continuously keep talking about, and it is walled off. Basically, like a quarantine zone is established, and basic on the on the outside layers, there's clusters of epithelioid cells. So I'll tell you what epithelioid cells are. They are basically a type of activated macrophages. Okay, based on some signal that they release, which we'll see, they become they differentiate into an epithelioid type of macrophage, and they wall off this area. And within the walled off area, you can see Langerhans giant cells, which are basically macrophages just uh, clumping together. So they fuse into one another, and they form a giant cell, because more hands are easier to deal with the pathogen than just one macrophage individually attacking it. So they form a giant cell. That's why you can see multiple nuclei within the Langerhans giant cells, and there will be other individual epithelioid cells also in between, and there will be some eosinophilic material. Like I mentioned in the previous lecture, eosinophilia usually correlates with like dead necrotic material, and that is what you'll see, the cellular debris and dead white blood cells, all of them would be in there, usually on microscopic, no, gross pathology. What you would see, suppose you would take a section of that organ, you would see that dead caseous material that I had mentioned in the first lecture. It causes caseous necrosis, usually seen in tuberculosis, fungal infections, and certain other types of bacterial infection, like not tuberculosis, another type of mycobacterium. So all these cause caseous necrosis, that white cottage cheese like dead material in the middle. So this is the mechanism behind granuloma formation. This is a very important mechanism because there are many diseases that that specifically form granulomas, and therefore it's very questionable. So how a granuloma forms is basically in a region where there's injury or there's an external antigen present, like maybe Mycobacterium, TB, or a fungal antigen. The antigen presenting cell, usually a dendritic cell, or could be a Langerhans cell, which is a macrophage that resides in different areas of the body. So they are like surveillance cells of that area. They'll reside in that local region, and they will react to these antigens. They will phagocytize this antigen, they will degrade them, and they will present them on MHC class 1, which we will see in a bit. MHC class 2, I think, we'll see that in a bit. But eventually, because of that presentation, the T cells, which T helper cells, CD4 positive T helper cells, which Ashwin talked about before, they come and they look at the antigen that's presented, and based on that, they start releasing IL-12. IL-12 helps in the differentiation of the naive CD4 T helper cell into a T helper cell type 1. So Ashwin had mentioned before, there was two types of T helper cells at the end. There's Th2 and Th1. So IL-12 release from this interaction between the APC and Th0, what they call it, between the naive T helper cell, that IL-12 that is released in this process causes the T helper cells, all the naive ones, to differentiate into T helper cells type 1. So this T helper type 1 is important because they secrete a specific type of cytokine. Th2 secretes another type of cytokine. Th1, which is important here, secretes interferon gamma. Interferon gamma is a cytokine we have seen a little bit before, but what it does basically is causes macrophage activation. So there will be macrophage coming into this area of inflammation, and interferon gamma activates these macrophages. So what do I mean activate? So you saw those epithelioid cells that walled off. They are also a type of macrophage. So these interferon gamma causes the macrophage to differentiate into these different types of the subtypes of macrophages, like epithelioid cells and giant cells. Yeah, and then there's also like a positive feedback loop where macrophage also secretes TNF, and then TNF causes more secretion of interferon gamma. But TNF is also another mediator that the macrophage secretes, and which is also important in epithelioid formation and giant cell creations. So interferon gamma activates macrophage, then the activated macrophage secretes TNF alpha to create the epithelioid subtype of a macrophage, and also cause them to fuse together and form giant cells within the walled off area. So there is a lot of clinical correlations in this, and one of that is because TNF is, as we all know, is one of the initial mediators of inflammation. So TNF and IL-1, as we've seen before, initial mediators of inflammation. So what happens is, in a lot of diseases, there's unnecessary TNF going around, like these chronic inflammatory diseases. So what happens is, there's these therapies that we have developed is to target these TNF, like literally have an antibody go and bind to that TNF or bind to a TNF receptor, so that this TNF interaction does not cause more inflammation. So what happens in this case is, yeah, so you cannot form granulomas if your TNF is blocked, and usually patients who undergo TNF anti-TNF therapy need to be checked for fungal infections or TB infections, because like Ashwin mentioned, one third of the population of the world is infected with TB, like latent TB, especially in developing countries. So what happens is, even if they're latent TB, they'll be walled off in a granuloma, and you will never have any symptoms, or you would never notice it. But once you start taking this anti-TNF therapy, there's not enough TNF to maintain the granuloma formation. The granuloma breaks down, and the tuberculosis, now which was initially walled off, is able to spread. It can cause disseminated disease, and there's no containing the tuberculosis now, so it's just gonna affect all types of organ systems. So that's one thing you need to keep in mind, and this is also a very questionable point, because they'll be like, a person who is going to be started treatment for rheumatoid arthritis, what should you be checking for, something like that. And also one important clinical correlation is that these activated macrophages, they have an enzyme called 1 alpha hydroxylase, which is one of the steps involved in vitamin D metabolism, so creation of vitamin D. So 1 alpha hydroxylase activity increases, then the amount of vitamin D in your body increases, and as we all know, vitamin D is important for calcium absorption, and therefore you will have excess calcium absorption. This will lead to hypercalcemia, meaning increased levels of calcium in your blood. So you can think some of these granulomatous diseases that cause granulomatous inflammation, can have hypercalcemia as a side effect because of this increased activity of 1 alpha hydroxylase in the activated macrophages. That is also pretty important to know. This is just another picture. Again, just a summary. APCs through MHC type 2 will present the antigen to the naive T cell, which is CD4TH0, and then it will recognize through this, and IL-12 is secreted in this interaction, which causes activation of the macrophage. No, sorry, conversion of the naive T cell into the T helper 1 subtype, and then T helper 1 subtype will secrete interferon gamma, which will cause the macrophage to differentiate into an activated version, and the activated version will then secrete interferon gamma, if I'm correct. No, no, not TNF, sorry, TNF, to cause the differentiation into epithelioid and giant cells. So that is the whole process that we saw behind granuloma formation. So you can imagine, if you have also interferon blockers, then you can affect granuloma formation, or something wrong with IL-12 receptors, then also there will be a problem in this process. Yeah, this is just the diagrammatic representation of how anti-TNF therapy works. So TNF is in the blood, the medicine comes and binds the TNF, so there's less TNF available, so you cannot form the granuloma. This is a histological slide of a granuloma. As you can see, all these dark blue spots are nuclei of lymphocytes, and they have, because lymphocytes have low cytoplasm, you don't see their cytoplasm, they all clump together. So lymphocytes, and this is a picture of a granuloma. You can see an giant cell here, which is basically fused macrophages, and you can also see the walled off area. These are the epithelioid macrophages. And yeah, there's no necrotic material over here, but I think I have a slide of that. So in pathology, so just like I told you, you can see within the granuloma, you can see some epithelioid cells, central macrophages, multinucleated giant cells, and then the surrounding area, it's surrounded by lymphocytes and fibroblasts. You can see some fibrosis here because this is collagen being deposited. Collagen usually is also bright pink because of eosinophilia. Yeah, so things you can look out for inside a granuloma are some things called asteroid bodies and Schaumann bodies. So these structures are really specific to be found inside granulomas, specifically within the giant cells. Um, because in some diseases, once you take a pathology slide, because once you take a pathology slide from a biopsy, once you see these structures in the granuloma, then you know it's a certain type of disease. Usually these correlate with sarcoidosis. So asteroid, but I'll just show you a picture. And there are two types of granuloma as well, caseating and non-caseating. So as I mentioned before, tuberculosis and fungal infections have this central necrosis, and they have some lipids and fatty layers in their cellular structure. So it causes this caseous, cheesy, white kind of necrosis, that is caseating, versus other things that do not have this fatty cells and fatty acids within them. They cause non-caseating granulomatous inflammation that happens in most autoimmune mediated diseases and foreign body exposures. So these, as you can see, this looks like a star. So this is an asteroid body. This dark material actually represents calcification, and calcification is commonly seen in Schaumann bodies. And this is the giant cell. Obviously, these are all within the giant cell. You can see two asteroid bodies. So if you actually want to know, asteroid bodies are just eosinophilic inclusion bodies consisting of various lipids. Schaumann is actually some intracytoplasmic calcium and protein complexes. So that's why calcium stains really dark on this HNE type stain. This is another granuloma, but in this case, this is caseating necrosis in the middle. So this is a granuloma. You can see multinucleated giant cell, and this is the granuloma area surrounded by lymphocytes, all these dark blue nuclei. This would be central necrosis. So it's probably like it is a tuberculosis infection of the lungs. This, on the other hand, you don't see caseating necrosis, but you do see multiple granulomas. So these are the walled off areas with fibrosis and lymphocytes, and within them you just have just inflammation going on within the granuloma. This is an immune mediated condition. This is called sarcoidosis, which causes chronic inflammation, chronic granulomatous inflammation, but no necrosis in the middle. So that's why you don't see that dark pink layer in between. Um, yeah, and also in sarcoidosis, as I mentioned before, since they have multiple granulomas, they have increased 1 alpha hydroxylase activity, and therefore they'll have hypercalcemia. So that's usually a sign of sarcoidosis. You can check in patients. These are different types of etiologies. There's infectious, immune mediated, and because of foreign bodies. So if you just divide yourself according to that, you can make sense of them. Um, Infections, most common causes of granulomatous inflammation, but things you can remember are fungal, especially mycobacterial like tuberculosis, leprosy, and all the mycobacterial diseases. But we'll cover once we go through each bacteria as well what type of inflammation they would cause. We would see them. Cat scratch disease, listeria, and syphilis. Immune mediated, like I said, sarcoidosis, but a few others as well. Foreign body exposure is interesting because berilliosis, talcosis happens in people who are exposed to beryllium or uh, talc in their occupation, and they will have chronic beryllium in their lungs. Then macrophages go phagocytize that, and then it causes the inflammatory reaction. So it leads to granulomatous inflammatory reaction. Breast implants is also another thing that can cause granulomatous inflammation because it contains silicon, and silica is another type of this material that triggers granulomatous inflammation. And yeah, so this is a kid with infection. The mother had an infection of listeria, and that had been transmitted to the kid. And this is also a granulomatous infection. And as you can see, these small spots are actually probably condensation of granulomatous tissue. You can see this is the granuloma that's formed. There's no caseation. This is just this is empty.
Abhi,
Yeah.
there's a question: is talc allergenic substance? Is talc an allergenic substance?
So its allergic properties would depend on the person. Like, if they have an allergy towards talc, it's usually not a very allergenic substance like peanut, which is one of the most common ones. But talc, in this case, what happens is, once suppose they are working in some kind of sandblasting or some kind of occupation where they're exposed to talc in the air, they breathe it in and they will get deposited in the lungs. So our lungs are usually cleaned by macrophages, and once they start cleaning that up, it triggers an inflammatory reaction, not a allergic type reaction. We'll look at it later once we are discussing the different types of immune reactions. Allergic usually goes towards like IgE, eosinophils in that area. This is like a granulomatous chronic inflammation which goes through macrophages and then epithelioid granulomatous formations and stuff like that. Does that answer your question? Yeah, so this is just an example of granulomatous infection. This is cat scratch disease. So this kid probably was playing with a cat and probably got scratched in his hands on this side of the body, and the infection travels up to the lymph node, and the lymph node quarantines the bacteria that's responsible for uh, the disease. And what happens is it produces a granulomatous inflammation, and that's why this is a swollen lymph node in this kid. Um, Next we have neoplasia. 1 second. Yeah. So do you guys have any questions up till now? Mm,
There is a question in the chat box.
1 second. Yes, that is also true. Chronic exposure to these things like beryllium, talc, even sometimes farmers get it because of exposure to pigeon antigens, chicken antigens. It triggers an hypersensitivity reaction over a long term, and it can cause fibrosis. And after fibrosis, they cannot breathe properly. They'll have pulmonary hypertension, heart failure. But yeah, these talc can cause those kind of problems as well. Yeah, so we'll begin with neoplasia. So neoplasia, just from the word neo, new, and plasia, molding. So molding or growth. So new growth. So it basically excessive proliferation of cells. Neoplasms usually are made of two components. One is the parenchyma, and the stroma. So usually parenchyma contains the neoplastic cells, and then the stroma is basically the support system of that neoplasia, like those cells. So they need blood vessels, they need some framework like connective tissue, collagens to like hold them together. So that is present within the stroma. Usually, neoplasia refers to proliferations which are monoclonal, meaning one cell type is the one that is being replicated. There are no two different cell types replicating independently. Neoplasia can be either malignant or benign. Malignant meaning cancerous, uh, meaning it can cause some damage and can lead to death, versus benign, it is not harmful, but it can cause symptoms based on if it's where it is, like it can press on something, or if it grows too much, lose blood supply, something along those lines. So this is just a recap from last time, so I'll go through this pretty fast. Normal cells, usually they have this is a normal structure, epithelial cell layer, there's a basement membrane and a basal cell layer as well. Basal cell layer usually has the stem cells required to create these epithelial cell layers.
Abhi, there's a question. It says in transitional epithelial areas. I just saw it. I don't know if she mentioned it a couple of slides before.
In transitional epithelium areas, can you specify? I might have missed where exactly it was.
There. Just check your stop moving.
Yeah.
Sorry, can you hear me? Because usually my mic doesn't work.
Yeah, we can hear you.
Can you hear me well, or is it just messy?
No, we can hear you well.
Oh, cool. So, what I meant was to ask regarding when you said that, like, in regard to neoplasia, right? So it's a monoclonal, which means like only one type of cell that could proliferate, right? So when you mentioned it, like the fact that we can consider two type, like consider only monoclonal, does this happen in transitional epithelium areas? Like for instance, when transitional epithelium from type of epithelium that we have, like for instance in esophagus as opposed to entry to the stomach, right? So the epithelium changes, or when it comes to I think papilloma virus, like for instance
Yeah.
vaginal area into the uterus and so on. And so this, like, does this happen usually in those areas? So
Yes. Yeah. So I get what you're mentioning. So the thing is, transitional epithelium, just by the name, is actually an epithelium that's only found in the bladder, the kidney, and no, not the kidney, the collecting ducts. But I get what you mean by the transition zone. Is I think what you mean. Transition zone is usually the area where one cell type converts to another cell type. Yes, in
yeah,
that. Yeah.
that's what I meant.
In that area, what happens? Yes, because of HPV infection, because of some mutations, it can cause uncontrolled cellular proliferation. Or in case of the esophagus, when you mentioned, it was the chronic acid stress that can lead to metaplastic changes. So these mutations, what happens is once there's a trigger mutation that somehow releases the checkpoint of cell cycle, it starts dividing uncontrollably. But initially, there was just one cell type. Of course, later on, what happens is this one cell type obviously will accumulate mutations over time, and eventually they will also give rise. But initially, neoplasia is termed based on like the initial cell type that underwent the trigger mutation.
Oh,
That is
so
why
it
they
doesn't have to do with like two different cell types where,
yes
like,
in
from the get-go, we're talking about one cell type that goes through proliferation, and it's
yeah.
not like invading to a place where it's not supposed to be. It just proliferates.
Just proliferates, yes. In
And
once it goes into the later stages of carcinoma, it can have multiple mutations. They'll have polyclonality. They will have so many DNA mutations. That is part of the reason why we cannot target them individually, because they are so different. But initially, neoplasia is just excessive proliferation of one cell type.
regardless to whatever it is, right?
Yes.
I understand. Thank you.
Okay. So yeah, neoplasia can be malignant or benign. So yeah, quick recap: epithelial cells, basal cell layer with the stem cells, and basement membrane, and we have the blood vessel. So these are the normal cellular architecture. And then once there is mutations, so either like Leah mentioned for HPV or chronic acid stress, once there are mutations that accumulate, it causes dysplasia. And dysplasia, usually the severity is determined by the thickness, how much of the thickness it affects. So mild, moderate, severe goes according to 1/3 of the full thickness versus 2/3, and greater than 2/3. So once it covers the entire full thickness, it's called carcinoma in situ. So this is an irreversible change, because the basal stem cell layers also have undergone dysplastic changes, and because of that, they cannot regenerate or have their normal function. So this area is still not considered invasive carcinoma because it has not invaded the basement membrane. Invasion of the basement membrane is one of the most important criteria to distinguish between invasive cancer and carcinoma in situ. In situ means in its place. So the full thickness is affected, full thickness is dysplastic, severe dysplasia irreversible. You can see those signs like a high nuclear to cytoplasm ratio, uh, and increased chromatin staining, pleomorphism, my high mitotic figures, things like that. And then once this cancer develops the ability to penetrate through the basement membrane, by that I mean it uses metalloproteinases, because basement membrane is just basically a support structure filled with uh, proteins, collagens and proteins, and which can be degraded by these metalloproteinases. Examples are collagenases and hydrolases. They basically like start degrading through the basement membrane once these become active. And also cells are usually stuck together so that they don't lose their form or go somewhere else. They're stuck together by something called e-cadherin. You can think of it like epithelial, so things that keep the epithelial cell together is e-cadherin. So adhere epithelial cells. So once the mutations are so severe that if it affects an e-cadherin and causes a loss of function mutation, the cell to cell contact is lost. Now they can like freely start flowing wherever they want, start proliferating, because all of these cells have cell cycle problems. You will get invasive cancer, and then once they reach the blood vessels, they'll start uh, spreading to different organs, blood vessels or lymphatics. In that case you call it metastasis. This is again a similar picture, just carcinoma in situ, keep in mind, is full thickness but has an invaded basement membrane. Invasive is invasion of the basement membrane by metalloproteinases. And also these cancers need some nutrients to grow even further, because they're growing rapidly. So what happens is they release all these angiogenic factors, which Ashwin had mentioned, VEGF, fibroblast growth factor, and VEGF, fibroblast growth factor, and there's one more, yeah. Okay, I am not sure, but yeah, those two definitely.
EGF, is that it?
Sorry,
EGF?
EGF doesn't do this thing, yeah. I think it's just those two, FGF and VEGF,
Or
yeah.
TGF beta, if you meant
Okay,
angiogen.
yeah, okay. TGF beta. So those factors, they can promote angiogenesis, and which will now supply the cancer with nutrients, and also the pathway to uh, go to different places and establish their metastasis. This is a picture of ductal carcinoma of the breast. So as you can see, this is each duct in the breast, and the thing is you don't see any invasion happening, like all these necrosis and all these cellular dysplasia. It's dysplasia because usually it's not supposed to be this crowded with loss of proper architecture, otherwise it would actually look like a tube. In this case there's like overgrowth, there's necrosis in the middle, and also there's the nuclei are really dark, almost looking like lymphocytes. So, and probably lymphocytes have infiltrated because tumors are foreign, and tumors are trigger for inflammation, but still this is dysplasia. And but main thing to notice is it hasn't invaded this capsule or this basement membrane. So this is called ductal carcinoma in situ. So wherever you see, so if you see cervical cancer, you call it, if it hasn't invaded the basement membrane, you call it cervical cancer in situ. The next example is, okay, this is a gross pathologic image of a metastatic tumor to the liver. So this is metastatic. One important thing to know is that if there are multiple nodules, it's most probably metastatic than just a primary liver cancer. Primary liver cancer, so this would relate to your question before, is that primary liver cancer, since it is monoclonal in origin, it will grow in one area and it can probably only survive in that area. But once the mutations start developing and it establishes polyclonality, it would then be able to invade into different organs. And in this case it probably came from the colon, because that is one of the most common causes of metastasis to the liver. This again, there is no invasion of basement membrane in this one. So even though they have come down, like there is dysplasia, but this layer, you can see a clear, something is like a test tube like thing holding it back. So the basement membrane is still intact. So this would be like CIS, like full thickness dysplasia, but no invasion. So we'll look at some quick tumor nomenclature. So carcinoma is the name given to any cancer that is of epithelial cells in origin. Epithelial cells are things that you'd find in like mucous membranes or in your skin or in like surfaces that are in touch with the outside. Sarcoma is the name given to cancers that develop from cells of mesenchymal origin. Mesenchymal is usually like connective tissue and muscle cells, those kind of tissue, which are much more inside. Well, not really all of them are inside, but yeah, like muscles, connective tissue, some kind of support and structural thing. Epithelial are more on the surface. Benign versus malignant. So you guys probably know this difference. Benign means it's usually the tumor will have well differentiated cells, well demarcated boundaries. It won't be like it won't be invading the basement membrane, and like even the dysplasia you see would be like mild, and there will be no necrosis, just like some increased cellular proliferation. Malignant, on the other hand, it'll be poorly differentiated because there'll be too many mutations, irregular boundaries, uh, irregular boundaries. Yeah, so because once they start invading the basement membrane, they won't maintain the structure, and also pleomorphism is a characteristic of dysplasia. So once it's severe, you can see high mitotic activities, figures, high mitotic activity, and also you can see those dark mitotic figures. You can also see necrosis, and there will be metastasis in malignant organs. Uh, just two just two names, hamartoma and choristoma. Hamartoma is the name given to disorganized overgrowth of a tissue in their own location. So if muscle overgrows in its own location, muscle cells where it's supposed to grow, but it's just a disorganized growth, you call it a hamartoma. Versus choristoma, growth of one type of tissue in a location where it's not supposed to be. So this usually happens in an example would be Meckel's diverticulum. So it's like outpouching in your intestine, and usually you can find gastric mucosa in your intestine. Usually it's not where it's supposed to be. So that's an example of a choristoma. These are just differentiating factors between benign and malignant. I had mentioned most of it already. So benign is well differentiated. It'll be slow growth, and necrosis is very rare. Probably won't even be present. It'll be well demarcated boundaries. No metastasis. Relapse is rare. The exact opposite for malignant. You can see all the cellular atypia, polychromasia, increased activity of nuclei, numerous mitotic figures, and metastasis is common. So this is a picture of, wait 1 second. This is a picture of, I just want to take, yeah. So this is a picture of a breast adenoma, and you can see, yes, there is like, it looks disorganized, but there is clear fib fibrous boundaries between each structure. Yeah, this is not a very good example because, okay, you can see some ductules. I think I might have a normal breast. No, this is not normal. Yeah, so you can see some ducts like structures, but they are all dysplastic, and there's also fibrosis, but there is no actual increased dysplasia. Like the nuclei are not really dark. Versus this one, you can see all these dark nuclei. The nuclei are actually really big compared to the cytoplasm. Here you see small nuclei, lightly colored. This is dense, dark, more sinister looking. So this is breast adenocarcinoma. Yeah, so this is just nomenclature again, depending what you call it based on its origin. So the name would basically give you the origin, what type of cell it originated from. So epithelial things, I told you they're called carcinoma. So benign ones are called adenoma or papilloma. Malignant ones are called adenocarcinoma or papillary carcinoma. So you just add carcinoma at the end and it becomes malignant. In mesenchymal, there are different types of mesenchymal tissue, so smooth muscle, striated muscle, all these support structures. Um, if there's cancer of the blood cells, you call them leukemia, lymphoma. That nothing you can get from the name itself. That, well, you can actually. Leu means white, and emia means in the blood. It's just white cells in the blood. So this would be excess white cells in the blood. Lymphoma, yeah, blood vessels. Hemangioma. So hemangioma means benign proliferation of blood vessels, but it's benign. So if you want to make them into malignant, you got to add that suffix, prefix, suffix. Yeah, you got to add that suffix, angiosarcoma. So smooth muscles are called benign proliferations are called leiomyoma, leiomyosarcoma. Striated muscles, rhabdomyoma, rhabdomyosarcoma. Fibroma. So you get the idea. Except for melanocytes, benign is called nevus or mole, and malignant is called melanoma. Just that. These ones follow that pattern. Yeah, there's more tumor nomenclature. There's you need to know what differentiation means. So tumor tissue that resembles the original cell type. So this again comes back to that monoclonality and polyclonality. So well differentiated tumors are either in their beginning stages, or they are going to be less aggressive tumor, and they usually have better prognosis because the original cell type is preserved, and that means not a lot of mutations have occurred. Versus poorly differentiated, it means so much mutations has happened that you might not even be able to tell the cell type of origin, and it's usually associated with more aggressive tumors and worse prognosis for patients. Anaplasia is like complete lack of differentiation. So suppose you're in one type of area in your body, suppose you're in your thyroid gland, and then you see like some completely different type of tissue in that area. That is anaplasia, and there will be different types of cells within that anaplastic, because each cell won't even represent each other. It's completely There's complete lack of differentiation. So the things that you can look for that indicate poor differentiation is high proliferation index. So there's this marker using while staining, you can stain for the specific protein, which is they are in highly differentiating cells, highly proliferating cells, sorry. So that would be an indicator. Presence of nucleoli, giant cells with multiple nuclei, hyperchromasia, abnormal shape, which is like pleomorphism, different cell polarity, different orientation, increase in mitotic figures. So all these things that we saw in the first lecture, which relates to dysplasia, if you see a lot of them, it basically means there's poor differentiation and high the cell is highly dysplastic in nature. Sorry about that. Um,
There's a question in the chat box.
yes, sorry. Uh, Cancer markers. Do you mean about the indicators of poor differentiation? Yes. So this high proliferation index specifically also is something that you can stain for, and it's a type of marker. It's called Ki67, and it would indicate like increased cellular proliferation, and even the others are like markers for poor differentiation. Um, yeah. So we see here, uh, okay, you won't be able to guess the original organ obviously because this is an anaplastic thyroid carcinoma. So for this to make sense to you, you need to know what a normal thyroid gland looks like, and this is how a normal thyroid gland looks like. Uh, so these are follicles, and these are like cells surrounding. They are producing all these thyroid hormones, and these contain iodine and all that good stuff. But what happens is you can develop a type of cancer called anaplastic thyroid carcinoma, and as you can see, there's no resemblance of this to this. Like that's all you need to know. This is anaplastic thyroid carcinoma, one of the worst type of cancers you can get. Probably you can end up dead within 6 months. And as I mentioned before, anaplasia, complete lack of differentiation, very bad prognosis. Probably there's especially no cure for this. Tumor grading. So we need you obviously have heard of these terms of stage 1 cancer, stage 2, stage 3, but those are tumor stages. But we also need to grade the tumor because like I mentioned right before, the differentiation of the cells matter, because well differentiated is a less aggressive tumor, so it's better prognosis. So based on differentiation, you can determine the clinical outcome of a patient. So that's why there's grading systems. So one commonly applied grading system, which you can keep in mind, you don't need to memorize any of this. This is just for your information. One tumor grading system, AJCC, what they grade based on differentiation. Again, well differentiated, moderately differentiated, poorly differentiated, undifferentiated, or anaplastic, or if like there's some sampling error or something of the biopsy. So this grading will also put like show what kind of outcome the patient will have. Obviously, G4 has a worse prognosis than G1 just based on this alone. Then and also this this was something you can see in the cervical cancer example. So CIN1 carcinoma, sorry, cervical intraepithelial neoplasia type, I mean level 1, mild dysplasia. There's, we covered this last time, but there's less than 1/3 of the full thickness. This is almost 2/3. This is greater than 2/3, and this is full thickness carcinoma in situ. So this is called low grade squamous intraepithelial lesion, and this is high grade squamous intraepithelial lesion. And eventually, once the basement membrane is penetrated, it would cause invasive cancer. TNM staging, this is one of the main things that people look for when they decide the stage of the cancer. Just know that there's T, N, and M. T means tumor size, N means nodal status, M means metastasis. So T tumor size depending on the size of the tumor. T1 is less than 2 centimeters, like that. It goes based on the size of the tumor. N is how many lymph nodes are affected. So N0 is like no lymph nodes are affected. N1 is like the same side one node, and then so on. Like, you know, more nodes are affected, the worse, I mean, the more number N3 you have. And then M is just basically yes or no, is there is a metastasis, meaning is the tumor present in an organ outside of its origin. So if it is, then it's M1, and that obviously puts you directly at stage 4 cancer. So this is just a small example of breast cancer. In breast cancer, if the tumor size is less than 2 centimeters, T1, no lymph node. Just I'll just skip this because it's the same slide. This again is how the staging is based. So staging is based on tumor size, and also if there is a regional lymph node metastasis. That is not actually considered, that is metastasis, but in distant metastasis it should be outside lymph nodes, like in an organ or in some region outside lymph nodes. So that would give you the stages basically. So tumor size can put you at a higher stage, or nodal status can put you at a higher stage. But one thing that directly puts you at a bad stage, sorry, is stage 4, is if you have distant metastasis. So it doesn't matter the tumor size, it doesn't matter how many lymph nodes is affected. If the tumor is present in 2 different locations, you're at a stage 4, and this is obviously bad prognostic indicator. Now Ashwin will continue with this topic. So do you guys have any questions regarding this?
No.
Great.
All right, one second.
Yeah. So that was the introduction to cancer. So I'll talk about a few more aspects of it. Right. So we've talked about cancer and its nomenclature and its normal features. So there was this paper in the late 1900s that was written by 2 scientists, and they received a Nobel Prize for it, if I'm not wrong, on what are the hallmarks of cancer. This is just the name that they suggested for it, hallmarks. But basically, it's how what are the most important features of a mass of cells that make it cancerous. That everything that we know about cancer, the fact that it invades tissue, the fact that it keeps growing in size, and all that. What are the hallmarks of it? How do the cancer cells manage to do it? Right. There are 6 most important things, and later on 2 more were added to their hypothesis. The first, so we'll discuss all of them in an order. This is a summary slide of all of them, and we'll go through all of them in more detail. So the first thing you got to know is all the growth factors that we had mentioned initially, not just the growth factors, a lot more of the mediators that we talked about. There are three ways in which you can secrete it. The one that we are most familiar with and that we discuss a lot is the endocrine action. It's there in the diagram towards your right top corner. That is when there's a cell that secretes the hormone or the mediator and it travels through your blood, and the effect of which is in a distant cell. But there are two other mechanisms that are also important when you discuss cancer, which is autocrine and paracrine. Autocrine is when the cell itself secretes the mediator, and then the receptor for the mediator is also on the same cell. And paracrine is when the cell just excretes the mediator to its surrounding tissue, and the cell with the receptor is really close to it. So the genes that we're going to talk about usually have their effect through the autocrine and the paracrine secretion method. And the first word that we have to be familiar with is called a proto-oncogene. So proto-oncogene is what we have during embryogenesis that increases. So basically, proto-oncogenes function to increase cell division and inhibit cell differentiation and also decrease cell death. You might think it's counterintuitive, but during the process of embryogenesis, when we are growing and when we want cells to proliferate, this is actually exactly what we need, right? We want proto-oncogenes. We want factors that help our genes to code for more cells that are responsible for replication and proliferate more. But after embryogenesis, we need these factors to be inhibited to calm down and to not function basically. Due to mutations, these cells can be inappropriately activated, and that can cause errors in replication, which will give cancerous cells its properties. So when proto-oncogenes become inappropriately activated, it's called oncogenes, and that can happen in many shape and forms. Few of which I've mentioned here in A, B, C, in A, B, and C in the top left, bottom right corner. So the first one is when there's a code in the DNA, in the genetic code, and as we know, the DNA is made up of base pairs. And if there is any kind of mutation that changes the base pairs, an adenine becomes a thymine or a guanine becomes a cytosine, and that can code for a completely different protein. So protein as such has a lot of portions to it, right? The RNA molecule that codes for the protein, it has an initiator sequence, it has the mRNA itself, and it has an inhibitor sequence at the end, which so there are functions for each of these sequences. One of them is responsible as an initiator, one of them is responsible for the structure, one of them is responsible for the function, and so on and on and on. So if any of this base pair is affected and there's a mutation which results in a protein that is self-sufficient or that is hyperactive or that is perpetually active, any small change can cause a proto-oncogene to become an oncogene. It can also be something as trivial as gene amplification. So there's a small genetic code, let's say TAG, right? Thymine, adenine, guanine, which are the three nucleotides. And suppose they repeat 10 times in a certain sequence of in a certain sequence of your DNA, and all of a sudden there's a mutation that makes it repeat 20 times. That is gene amplification. That will result in more protein production. Or, like we mentioned in the initial lecture, Malika even brought it up today, where there was a translocation, where two chromosomes chopped each other at their ends and joined together to form a new chromosome, which was an amalgamation of the both in follicular cancer, where there was 1418 and 1517 in AML. When that happens, you have different coding sequences put together, because of which there can be an activating sequence which is put together with a substance that shouldn't be active, perpetually active. Let's say immunoglobulins. Immunoglobulins, as we discussed, are part of the adaptive immune system, which is a very specific type of immunity to certain pathogens, right? So we don't need this immune system to be activated when we are not under threat. When suppose we have an immunoglobulin that attacks COVID, for example, we have antibodies against COVID, right? But there's no point in making these antibodies when our body is not under the attack of COVID. But if there's a translocation and now we have an activating sequence in front of the gene that codes for this antibody, it can be active all the time, and we'll unnecessarily be producing the antibodies throughout, and that can have consequences. So translocations, amplifications, point mutations or deletions or insertions, all of that can lead a proto-oncogene to become an oncogene. The basic feature of a proto-oncogene is that it is pro-growth. It wants to proliferate more. And as far as that process is regulated, it's good, it's physiologic, it's needed. But the minute it becomes unregulated or there's a mistake, it becomes an oncogene and things go downhill from there. So usually what happens in these all these mutations that I have mentioned give the protein an excess function, right? So we have these immunoglobulins which are normally produced. By adding a sequence that is activating, we are perpetuating it even more. It is gaining a function, right? It's not a loss of function mutation. Suppose you have so we'll discuss another set of another group of transcription factors or mediators that are called tumor suppressor genes. What happens in that case is they are trying to limit growth, and when they lose their ability to limit growth is when we have problems. But in this case, proto-oncogenes gain excess ability to cause growth. Proto-oncogenes in itself can cause growth, but because of the mutation, they do it in a very unregulated fashion, and they actually amplify their effect. That's why it's a gain of function mutation. It is really important that you understand that whatever type of mutation happens to the proto-oncogenes, it's a gain of function. They they're there for a reason, and now because of the mutation, they amplify the cause. They do it much more frequently than they're supposed to. And usually in humans, there are 23 chromosomes and they're paired, and we have 46 in total, 23 from the mother and 23 from the father. And so every chromosome has two alleles, one from the mother, one from the father, or a combination of both. So when this mutation takes place for proto-oncogenes, if either one of the alleles are affected, it is more than enough for the whole product, for the whole protein to be malfunctioning. You have to remember two things when it comes to proto-oncogenes. One is that the mutation is a gain of function mutation, and second, that only one allele has to be affected. So the next slide, I'll show you different components of the pathway that can be affected, which can result in excess cell growth. So think about it. We talked about a lot of growth factors, right? Like EGF. So suppose there's a process in which you make excess EGF. Obviously, it will result in more cell growth. Think about a scenario where there is no EGF, but the receptor of the EGF is being stimulated by itself. That will also result in more cell growth. Another scenario where there's no EGF and the receptor is not stimulated, but downstream processes are happening by itself. Like we discussed about tyrosine kinases, right? They work in the cytoplasm. They work in the cytoplasm when the cell surface is stimulated by something like a growth factor. But imagine a scenario where there's a coding error and now they're perpetually activated downstream. That's when you have an activation of signaling molecules. That can also result in excess cell growth.
Is it more like I'm sorry. Is it more dangerous that way, that we don't have any kind of like
so any one of this any one of this can be dangerous, but the further down the pathway you go, the lesser the mechanisms you can like we have some, let's say, therapeutic targets, like suppose we can supplement it or we can try to stop the growth factors from attaching, but the deeper the process, the harder for you to target it. Does that help?
Like yeah, that's what I meant when it's that deep. That's what I meant. Like, is it more dangerous that we don't know because there's no signaling factor? Like
exactly,
like it's like a light, like when you're driving in the street and the light doesn't work and you don't know if to stop the car or not, like in a way, right?
Yeah.
Like if like receptors do not signal that some sort of problem is going underneath, then it's like more
I get what you're trying to say. So at any point in this chain, things can go bad, and once it goes bad, like at the level of let's say transcription factors, it's kind of hard to target, like you mentioned. So so the deepest level would be cell cycle regulators. So signaling molecules go into the nucleus, then they code for transcription factors that attach to the DNA, and transcription takes place where DNA is converted to RNA. And also the next level, the utmost deepest level that it can affect is a cell cycle regulator. So basically, cell goes through different phases where there is a mutation, where there is a replication of the DNA, and then the replication of the cytoplasm, and then they become two different cells, two daughter cells. At any point, usually there are mechanisms in place for us to control the different manners in which the cell divides, and when they should divide, and how they should divide. But if there is a mutation there, and now they are dividing perpetually all the time and with mistakes, then that's dangerous. So this is what I had basically explained. So you can have a defect in the growth factor, you can have a defect in the growth factor receptor, or you can have a defect in any one of the pathways downward from there. So it's another really important thing for you to remember is that you have to remember the examples basically. So that's one of the things that USMLE can ask. Although some of them are theoretical, the reason why you have to remember everything is because they have clinical correlation. We are trying to make drugs that are specific. So as soon as there's a cancer and there's awareness about the cancer, people try to dissect it, try to find out what are the mutations causing the cancer, and try to target it. So when you know at exactly which step things go wrong, then you can try and make therapeutic options, medicines to target the exact step. So in this case, growth factors, one of the more we didn't mention about platelet derived growth factor. So that is one of the most, in case of astrocytomas, astrocytomas are commonly seen in the brain. It's one of the most common types of tumor. Astrocytes are part of the brain's, let's say, structural. So other than neurons, brain have a few other cells like astrocytes and microglial cells. Astrocyte helps in the structural formation. It also has a few other functions. So astrocytes can go malignant, and it can cause something called an astrocytoma. And in those tumors, the instigating factor, the main mutation that takes place is that the platelet-derived growth factor starts, what do you call it? So the platelet-derived growth factor should only be activated at certain points in time. But when you develop a mutation in that, it goes berserk and it's activated all the time. So all you have to remember is that in case of astrocytomas, the main mutation happens with platelet-derived growth factor. In case of breast cancer, a lot of you might have heard estrogen positive breast cancer, progesterone positive breast cancer. Another thing that we have targeted, and this is an amazing example of how we have managed to develop medication for different types of cancer, and it's a great stride forward in pharmacology, where we were able to realize that the receptor for a certain growth factor like ERBB2 is what results in the excess proliferation of cells in breast cancer. And we were able to create a medication called trastuzumab, which targets this exact step and helps us decrease the proliferation. I've mentioned it in the table to your bottom right corner, where we have a HER2 receptor, which is the receptor that is supposed to be activated only when when it attaches to, like, let's say, EGF growth factor. But in this case, it develops a mutation where it is perpetually activated, and now we were able to develop a medication against it, and we are fighting it with trastuzumab. So because of a clinical correlation, you have to remember that. And there are other molecules like RAS down the pathway in signaling molecules that also is commonly seen in cancers like pancreatic cancer and colon cancer. And another really important family of transcription factors is MYC, because there are different forms of this MYC protein in different parts of your body, namely NMYC, which is neuro brain. So neuroblastoma, not blastoma. So neuroblastoma usually has a mutation in the NMYC gene. c-Myc gene is mutated in Burkitt's lymphoma. Just like we discussed follicular lymphoma, there's a translocation of 814, 8th chromosome and 14th chromosome. There's a translocation in Burkitt's lymphoma, and that is c-Myc mutation. And there's also in lung cancer, you can see the mutation of MYC-L1. Even deeper in cell cycle regulation, you can see mutations in genes like cyclin D1, which is commonly seen in breast cancer and lung cancer. It's extremely important for you to remember the ones with therapeutic options. I mentioned trastuzumab. Another one is in chronic myeloid leukemia. There's a translocation of chromosome 9 and chromosome 22, which codes for tyrosine kinase. It was one of the ways in which the signaling molecules work. And we have developed an agent that targets that, and it's called imatinib. So you have to remember, and it helps you remember that imatinib is the treatment for CML. And just like that, for EGFR, it's epidermal growth factor receptor, and we have developed agents for that as well. The main two that you have to remember is erlotinib and also cetuximab. Sorry. Yeah. So since we're short on time, you need to go through all of them, but I'll just briefly mention that. Mention the rest. So I've put this table from first aid. It was not part of the portions for today's class, but because it was based on route memorization, right? We didn't want to waste time during class to tell you to go through the whole table, because I've told you the logic behind it. So basically, there are a lot of steps that can go wrong for proliferation, and at any point in time, if you develop a mutation, things can go wrong downhill. So you have to realize that all these proto-oncogenes have a small similar mechanism, is that there's a gain of function mutation, and only one allele has to be defective for them to go bad. And once that happens, you can have malignant cells. These are all examples of different proto-oncogenes turning into oncogenes. I've mentioned a few like BCR-ABL and c-Myc, n-Myc, and MYC-LY, MYC-L1, which is there in lung cancer. But the others, you can go through it. With the background that we've given you, it shouldn't be hard for you to understand them, but you have to put an effort to really remember which one goes wrong in which type of cancer. There's no logic to that. It's just, we found it out, so you got to know it. Like somebody has gone through the work of finding all this information out to create medicines, so we have to know them. So the next way in which we can, another hallmark of cancer is that not only do they proliferate more, but they die less. So it's a two-pronged sword. It works both ways. So the major difference in this is that I mentioned that in case of proto-oncogenes, you only need one mutation in one allele for it to go wrong. But in case of tumor suppressor genes, which is what we call them, you need two mutations. You need two hits. So because the reason for this is because the mutations developed in this kind of genes are recessive mutations. And briefly, if everybody's familiar with genetics, you'll realize that you need two alleles of recessive. You need mutations in two alleles if they are recessive mutations for the phenotype to be affected. In the genotype, if we have two recessive mutations, is only when the phenotype is affected. The most classic example is that of RB. It's called retinoblastoma gene, RB1, retinoblastoma 1, where children are usually born with one allele affected, one of their two RB alleles affected, and during the course of their life, they have one more mutation that goes wrong during the course of their life. And when these two mutations have I mess it up. So the children are born with one RB mutation, and during the course of their life, ecological factors lead to another mutation. And when two of these mutations adhere, like both of them happen, that's when they have retinoblastoma, which is a cancer in your retina behind your eye. That is just a classic example. All you have to know is the difference in this is that all of the genes, examples in tumor suppressor genes, are stuff that code for cell cycles to decrease cell proliferation. Proto-oncogenes were there to increase cell proliferation. This one decreases cell proliferation. So if they work properly, cells wouldn't be growing much. But since they're not working properly and they have aggregated 2 mutations, they don't work well. Yeah. Yeah, in case of retinoblastoma, during the course of your lifetime, anything that can happen. So that's what I meant by environmental factors. All the mutations that you acquire during the course of your lifetime is the second hit. The first hit, you're born with it. You have an RB mutation that you inherited. The second hit is what happens in one of the replications of your DNA during your lifetime. You develop the second mutation, and together they stop the RB gene from functioning properly. Yeah. So I've the mechanism of a few of them I've mentioned. I'll try to mention them. So the first one is RB. RB usually binds with E2F, which is an elongation factor. So for the RB to be active, it has to be hypophosphorylated. When RB gene is not phosphorylated, it binds to elongation factor, which is required for transcription. So if RB is binding to elongation factor, it doesn't DNA is not transcribed, as in there is no multiplication of DNA, and therefore there is no cell replication and there's no growth. If you phosphorylate RB releases elongation factor, and gene transcription takes place, and there's more protein, there's more proliferation. So RB, when it's hypophosphorylated, is binding to elongation factor and decreasing transcription. Now, there's another factor to it called P53. What P53 does is that, as you can see, some of you might be familiar with the cell cycle, and there are different phases. I want you to look at the phase between G1 and S. So before the cell goes from G1 to S, that is, before the cell starts replicating its DNA, is when there's a checkpoint where P53 will check the DNA for any errors. So it'll go through the... Yeah, good. Phosphorylation phosphorylation releases the elongation factor. If that happens, gene transcription takes place. So RB is like a security. It's holding on to the elongation factor and stopping it from transcription. But as soon as you phosphorylate it, it lets it go, and this goes and attaches to the DNA, and there's transcription. Now I'm introducing a new character, P53. P53 is at the checkpoint between G1 and S. So it checks the DNA for errors before the DNA replicates itself. At that point in time, if there is an error, there is one or two things that can happen if the P53 is functioning well. It can either stimulate BCL2. We had talked about it in last class, where I had mentioned that BCL2 is part of the apoptotic family. It can trigger apoptosis in a cell. So it can either say, okay, the DNA is too damaged, I can't do anything about it, but I'll kill the cell, kind of like a suicide, so that, I don't spread this mutation to the other cells. And it can die. Otherwise, it can say, like, well, it's damaged, but I can try and repair it. So what it does then is that it binds to a factor called P21, and that blocks cyclin kinases. Kinases are basically, anytime you hear the word kinases, you need to realize that kinase is kinases is a molecule that does phosphorylation. So if P53 binds to P21, it blocks the kinase. When the kinase is blocked, it doesn't phosphorylate RB. And when RB is not phosphorylated, it holds on to elongation factor. And when it holds on to the elongation factor, transcription doesn't take place. So that's the two things. P53 can either buy you time to correct the mistake, or it can kill you. But if either your RB or your P53 is mutated, this doesn't take place. So you start accumulating DNA mutations and you keep replicating. At one point, your cell will have enough mutations in hand for it to go rogue. And that's when it proliferates exponentially. So the normal Li-Fraumeni syndrome is a syndrome where you have mutations. I'll go crazy. So Li-Fraumeni syndrome is a syndrome in which you have mutations on your P53 gene, and you usually have problems like cancers like sarcoma, breast cancer, and adrenal cancer, and also leukemias. So again, it's a page on it's the same page on first aid with the proto-oncogenes. You have a lot of tumor suppressors genes on that page as well. You have to go through them by yourself and root memorize them. But this is you can understand the logic behind a lot of it, but to correlate which cancer is caused by which mutation, there's no other way around it. You have to learn it by yourself. Other mechanisms in place: evasion of apoptosis. We discussed BCL2 mutations are responsible for apoptosis, and if you mess them up, your cells just don't die. And if the wrongdoers don't die, they just they keep proliferating. And one example of which is follicular lymphoma. We talked about it last class. Another one in the cellular level. So all chromosomes have what's called telomeres. That is the last sequence in the chromosome. So DNA replication is usually semi-conservative. You have two strands, and replication happens only in one direction from 5' to 3'. It's a very short recap. You guys don't have to know the whole thing, but I'll keep it very brief. So 5' to 3', and there's one strand that is continuously transcribed, and the other strand that is transcribed in fragments. Yeah. So when the one that is transcribed in fragments, you need a primer for it, something for it to start transcription from, right? It's called an RNA primer. So if you do not have that RNA primer, at the end of the sequence, you cannot transcribe the last part of the chromosome. So as in when you age, you keep shortening your chromosome. And at one point in time, it's too short for you to undergo replication, and you stop replicating. And some people say that's how you age. The cells, they keep shortening their last sequence of chromosome. You keep chopping, and at one point in time, it's too short to replicate, and hence the cell dies. It's one of the hypothesized way of aging. So telomerase is another. So when you have the enzyme telomerase, which is usually present in the early part of your life, and some cells that are always replicating have them forever. So telomerase usually prevents this from happening by giving themselves a substrate for like a primer, like an RNA primer, so that the last part of your chromosome can keep replicating. When the DNA replication is taking place, your last part is not left out, basically. So it doesn't shorten. So when it doesn't shorten, you can keep replicating, and you won't die. The cell won't die. So that is one of the ways. So having telomerase is like having drinking from the fountain of youth. You'll always stay young, kind of like that for the cell. And another one is already discussed, the growth factors, VEGF and all that. Once they are present, you can make new blood vessels. When you're making a lot of cells, you'll need a lot of nutrients, and you need new blood vessels to supply these nutrients. So you have to make a lot of cells. This is one of the ways that cancer can supply their growth. Another one is called Warburg effect. It's really, first, it was very theoretical, and it didn't make a lot of sense, but now there are clinical correlations. So what you have to remember is that in cells, glycolysis takes place, glucose is converted to pyruvate. Pyruvate can go one of two ways. You can it can undergo the Krebs cycle, the much hated Krebs cycle. It can give out carbon dioxide, and it can produce a lot of ATP, or it can become lactate. So just glycolysis doesn't give you a lot of ATP, so it's not the most efficient process. But with oxidative phosphorylation, it produces a lot of ATP. But so first, they didn't know why it happened first. They didn't know why it happened first. They just knew it happens. Is that in cancer cells, the cells, glucose is converted to pyruvate, but instead of undergoing oxidative phosphorylation, it undergoes pyruvate to lactate conversion. So one of the reasons why they think this happens is because the tumor values carbon-carbon bonds, and it doesn't want to produce the CO2 in oxidative phosphorylation and waste the carbon bonds that you lose as CO2. But we have some clinical correlations. For Warburg effect. Some people, you might be familiar with PET scan. It's a modified CT. So what you do is you digest fluorodeoxyglucose or something like that, FDG, and once you digest that, you wait for the patient. You wait for a while, so as to, like, there's a marker in the glucose that helps you identify it when you look at it through a scan. So basically, you're looking for places where glucose aggregates. And since we know that cancer cells are really hungry and they need a lot of glucose, and because of Warburg effect, glycolysis is not the most efficient way, so they need much more glucose to make the pyruvate and the ATP, we realize that they are really glucose dependent. And the PET scan, the mechanism by which the PET scan works can be explained by Warburg effect, because now, since they're not making enough ATP, they consume a lot of glucose. So when you give the patient glucose and then you attach a label on the glucose, and then you look for the label on the scan, you will automatically identify the areas with the most amount of glucose absorption, and they'll inevitably be the cancerous areas. So when you want to identify metastatic lesions in the bone or some other parts of your body, or just to figure out which parts of your body are identified with cancer, have cancer, PET scan is what you do. And the reason why it works is the mechanism by which it works is this. And also, last year during the peak of COVID pandemic, there was a WhatsApp forward going on where a lot of Indian scientists came up with this new drug called deoxy-D-glucose. What they basically did was that they took glucose and they removed oxygen from two of the OH hydroxyl groups, because of which phosphate couldn't attach. And the second step in glycolysis is where glucose is converted to glucose 6-phosphate. And if that doesn't take place, anything downstream doesn't take place. So now, because of Warburg effect, we're familiar with the fact that cancer cells need a lot of glucose, and if that first second step of glycolysis doesn't take place, you basically starve your cancer cells. So 2-deoxy-2-glucose was one of the proposed mechanisms of fighting not just cancer. They even felt that it will fight COVID somehow. But yeah, those are the two correlations. And finally, yeah, in metastasis, Abhi has already mentioned this, so I'll be very brief with this. Metastasis, like we know, is the most important diagnostic factor. When they say that the cancer is stage 4 and stuff like that, what they mean is that the cancer is already metastasized. That means it's in multiple areas of your body. So that's when surgery becomes obsolete. You have to use other mechanisms to fight it. And that also means that the cancer has been long enough to accumulate a lot of mutations, and it'll be really hard to target it. And so metastasis is bad, basically. And there are 3 steps to it. One is when the initial tumor, the primary tumor, invades the blood vessels, and then first it reaches the blood vessels through invasion, and the intravasation is when it travels through the bloodstream or the lymphatic system, and then extravasation is where it reaches its secondary site, and it goes out and deposits there. We has already mentioned the way by which it does it, one of which is loss of E-cadherin, and also production of matrix metalloproteins, by which it digs its way through to the blood vessel. And then, so the basic thing to remember is that carcinomas usually spread by the lymphatic system, and sarcomas usually spread by the blood vessels. There is an exception to rule, and as usual, exceptions are really important in the step 1 exam. So you have to remember that the 4 carcinomas that spread through the bloodstream are thyroid, renal cell carcinoma, choriocarcinoma, and hepatocellular carcinoma. Briefly about metastasis, the most important one, important detail. Yeah, briefly about it. So you have to remember that the most common site where the carcinoma spread first, and the one that is usually sampled when you take a biopsy, is the regional lymph nodes. So that's why they do an axillary biopsy when they check for breast cancer, because the first drainage of the tumor is in the axilla. And after that, the first solid organ in which most tumors metastasize, most commonly metastasize, is the liver. Because liver has a dual blood supply. There's a portal circulation that collects venous blood from the stomach, the colon, and pancreas and all that, and drains it into the liver. So automatically, it's an easy way for the tumor to spread. And a primary tumor from any of these sites can spread to the liver. You have to remember that liver is a really common site, basically. And and also the fact that most bone tumors are from metastasis rather than it being primary bone tumors. So there are tumors like osteosarcoma, which is a primary bone tumor based from osteoblasts. But most commonly, if you have a tumor in your bone, it is highly likely that is from metastasis from some other area. And while you go through this presentation, go through the bottom picture in the bottom left corner. It's important for questions because they'll mention that just from mentioning the fact that the bone metastasis was osteolytic or osteoblastic, it should help you narrow down your differential to which primary tumor it is. So usually prostate cancer is the primary culprit that you think of when you have osteoblastic bone metastasis, as in more bone growth happens, that is osteoblastic, and when that happens, the primary tumor is usually in the prostate. And the second is a picture of multiple liver metastasis. We already had that picture. And also, same goes to the brain, like the bone. A lot of the brain tumors are also from metastasis, and the most common brain metastasis is from lung and breast cancer. Yeah, so obviously, when our immune system does a good job of finding out cells that are not our cells and attacking it, so cancer has to find a way to survive the immune system and not be attacked by it, and it does it. It does it by one. So we said something. We said something about antigen presenting cells, where you chop up the antigen and present the uh, extra, present the outsider on your cell surface to be recognized. What tumor cells do is that they downregulate the expression of MHC. MHC is kind of like, the helping hand for you to showcase the protein that you want the immune cell to recognize, and MHC downregulates that helping hand, and because of which our immune system cannot find out the tumor cells. And it also recruits the regulatory T cells, right? The ones that decrease inflammation. It recruits them and it kind of fights off inflammation. It also has a couple of other mechanisms, which we don't have the time to go into detail, but these are the ones that you have to remember, the ones to your left. Yeah, Abhi will take over now. Abhi. This is the last topic. Maybe 10 minutes max.
Yeah, we'll finish it.
Yeah, so immune checkpoints and their inhibitors. So, like Ashwin was mentioning before, the antigen presenting cell has to recognize some of the antigens, or it can also present some antigens to the T cells. So, so this is what the checkpoint is all about. Because once the T cell gets activated, T cells will start attacking whatever cells that has the similar antigen that they just recognized before. So the main thing you just need to keep in mind is there's a naive T cell, and it needs to recognize one antigen, which is usually present on a MHC class 2 molecule. MHC stands for major histocompatibility. Like, it's one of those things that people look for when they are doing organ donations or things like that, because those are like individual fingerprints. Then these MHC class 2 molecules, they present the antigens, like it can be a tumor cell, a piece of the tumor cell, or some protein expressed on the tumor cell. And once this naive T cell, meaning like it doesn't do anything as of now, recognizes with the T cell receptor, which is a CD4. What happens is CD2 and CD4. It also needs a co-stimulation. It needs a co-stimulatory signal, because just if it just recognizes this antigen, it will not be activated. It needs two signals for the naive T cell to convert into to a type of T cell that will have some effects, like maybe CD8 or depending CD4, actually CD4 TH1 or TH2. So this diagram shows a co-stimulatory signal and specific signal. So if the presence of both the specific signal, the antigen specific signal, and this co-stimulation, which the receptor on the T cell is a CD28 and the receptor on the antigen presenting cell or the dendritic cell is B7. So you have to know these again. I know these are just numbers, but you'll have to know them. So this co-stimulation by CD28 and B7 activates the T cell. So both of these signals present activates the T cell. But suppose only the antigen signal is present, but there is no co-stimulation, maybe due to a mutation or things like that. Then the T cell becomes anergic. Anergic means like it just does not function, and it will not die, but it will just stay there. It will not do anything. Um, because it lacks energy basically. Then if there is only a co-stimulation signal, then no effect on the T cell. The T cell will just get another signal and it will go about its way. But if it's anergic, then it cannot be made to do anything else. Like that T cell is done. It'll just live out its life like that. Yeah. So this is just another example in a virus infected cell how this would happen. So first, the naive T cell stimulated by virus infected dendritic cell. So the dendritic cell in this case acts as the antigen presenting cell, and then it's infected by the virus, and then it produces those proteins on the MHC class 2, and you can see the T cell receptor binding to MHC class 2 and CD4 with co-stimulation. So now the T cell would be activated. So the T cell recognize, then T cell is activated. Now it's just going about. So if any of your other cells have the same antigen, the same viral antigen that it has been activated by, if it's present, then it will go recognize that, and then it will start killing that cell. So this is how T cells will kill viral infected cells. But in cases the naive T cell recognizes self antigen on epithelial cells. So because sometimes even your normal cells also have MHC class 2, and sometimes they also present like your inner cellular protein or whatever was degraded, it can also be presented by your cells. So you don't want your T cell to be activated against your own cells. So what happens is, that's why this co-stimulation is important, that B7 on the normal cells and B7 and CD28. This co-stimulation is important because in our normal cells, MHC class 2 signal is the only one it receives. It doesn't have that co-stimulatory signal. T cell goes into anergy, meaning an unresponsive state, and it will not attack itself. Yeah, that is briefly that. And this is just a detailed explanation of which receptors activate the T cell and which inhibits the T cell. So again, like you just don't have one or two receptors, you have like quite a lot of them, maybe thousands of them on the T cell surface. And so it's a balance of how much positive to how much negative it's getting, and the net, if it's positive, then T cell will be activated. Net, if it's negative, then it will like energy or be deactivated. So the main receptors you need to think about is MHC class 2 with the T cell receptor, or the CD2 with that CD4 hand holding both of them together. That is a T cell activator. CD28 and B7, this is the co-stimulatory signal, and that also activates. But there's a exact opposite of CD28. It's called CTLA4. So CTLA4, if it binds the B7, both have the same ligand, but if it binds B7, it will cause T cell deactivation, or go into a state of anergy. So this is a negative signal. Then there are other signals as well. See, suppose on a tumor cell, if they can present with MHC class 1. So you can think about it this way: our cells usually present our own material in MHC class 1, and if it's some outside foreign viral DNA, it usually presents in MHC class 2. Sorry, viral is part of ours because virus just uses our own machinery, so it's also MHC class 1. But like bacterial or those kinds of stuff, where yeah, those extracellular components is presented usually on MHC class 2. Anyway, so MHC class 1, again, it can be recognized by the same receptor, T cell receptor, that is a positive signal. Then there's something on T cells, just like a mechanism to like shut it down just in case it goes wrong and they need a off switch. So it's called program death 1. So PD1 is a receptor on this, and whenever it encounters a program death ligand 1, the T cell will have a huge negative signal and it will cause it to shut down. So tumor cells, what they do, this is one of the immune evasions Ashwin mentioned, they start developing mutations that allow PDL1 to survive more on the cell membrane and express more PDL1. And because then T cells, sorry, yeah, and then T cells get T cells recognize this from the PD1 and then they undergo apoptosis or anything, energy, and the tumor cells can proliferate because T cells won't start attacking them. So they are pretty smart in the way it develops. So again, so since we know this mechanism, we can develop antibodies against it. So the main problem is the program, this one is getting into contact with this. So you can develop antibodies to like block this receptor or block this ligand. So that's basically what they have done. So PD1 antibody inhibitors will bind directly to the PD on the T cell, or PDL1 or PDL2 antibody inhibitors will bind to the ligand on the tumor cell. Both ways, you can use any one of them, but just to make sure that they don't come into contact and cause the T cell to have a negative signal. Again, this is a CTLA4. Again, I mentioned it was also a negative signal, so you don't want these negative signals. So in when you are fighting cancer, you want the T cell to be activated. So again, you can block that CTLA4 so that more times B7 would bind to CD28 than CTLA4. So that will keep more of the T cell population active. Yeah. And then cancer epidemiology. Ashwin will mention a few words, or I think you already mentioned most of it. Yes.
I mean, there's nothing much I can talk about. It's basically that you have to know this. It's really important, but there's no logic to it. So, in case of two things you have to consider: what are the most common cancers? What are the common cancers that most commonly kill you? The most common cancers, in terms of when you divide it gender based, in males, the extremely common cancer is prostate, followed by lung and colon cancer. In females, it's the same order except they don't have a prostate, so breast cancer is the most common one. In mortality, the only thing you have to do is switch one and two. Prostate and breast cancer, fortunately, kill less often, but lung cancer is a primary killer. So, things to remember: prostate cancer, lung cancer, and colon cancer is the most common. But when it comes to mortality, lung cancer kills more often than prostate. And in females, breast cancer is the most common, but lung cancer again kills most common. In children, the most common cancers that you'll come across is neuroblastoma, leukemia, and usually CNS tumors. Uh, it's just the same for all genders and everything like that. Other than that, it's just epidemiology, the fact that heart disease kills most common, but cancer is the second most common killer. But I think in 30 years from now or something, they expect cancer to be the number one killer. And also the fact that, you can correlate it to the fact with smoking that the number of male patients with cancer has decreased because number of males smoking, I guess, has decreased overall, but in females it is increased or stayed stable, because of which maybe that could be the reason why lung cancer has incidence in females is still the same, but it has decreased in men. Yeah, that is about it for incidents. So you guys should go through this page and the page after this, which talks about the most common sites of metastasis for each cancer. It's pretty brief, but it's something that you have to do by yourselves. There's nothing much to explain. Yeah. So homework would be to read all the proto-oncogenes and tumor suppressor genes, and also the common metastasis sites that we have not covered. Other than what's in the PPT, both of these things you guys have to take care of. Yeah, I think we've finally covered everything that we wanted to for today. Yeah, go ahead, man.
Weekends mostly would be nice.
We initially thought 2 classes a week, yeah. So if we do it together, it won't give you enough time to prepare. And we need 2 classes a week because we need 8 hours. As you can see, already we extended like 20 minutes to today. So clearly the timing is not enough. So we have to have 2 classes. So when you have 2 classes, I think it's better for us to spread it out through the week so that you have time to prepare. And it kind of helps that it's a small group, so we can come to a consensus faster. So Leah is fine with anything. Malia, so if it's night, yeah, so night on Wednesday is fine for her. Sainak, is it okay if we do that on Wednesday night for you?
Yeah, what time?
What do you guys think? 6?
I'll be reaching home by 6 because Wednesday I need to go to hospital.
Okay, 7? Maybe we can
Yeah,
try to keep it like 3 hours or something, and 7 to 10
that's
maybe.
fine.
Is that okay, Malia? Yeah, cool. Yeah, so then we'll send out the exact timings and the portions for the next class um, in a mail soon today. And the topic will be basics of microbiology, and we'll do questions. We'll do questions on the topics that we've covered up till now, and also if we have enough time, maybe we can start with a little of immunology. It'll help. So for every class, I think it's better we decide as we go. If we keep it stable, then there'll be a lot of disruptions. But if you guys prefer it, like every Sunday we can just ask and we can agree upon one of the weekdays. So that'll be better instead of keeping it rigidly on Wednesday. If something comes up on a Wednesday, we can do it on a Thursday as well or a Tuesday. It wouldn't matter much.
Yeah, that's fine.
Yeah. So about the payment, guys, with maybe. So how do you want to make the payment? Do you want to do it just by a bank